Good morning, everyone. Oh. Good morning, everyone. I'm Erin Burke-Lever, she, hers. I'm the Director of Community Engagement and Principal Investigator for our HRSA Spins HIV Aging Initiative.
And I'm Haley Sanner, she, hers, Healthy Aging Programs Manager at Colorado Health Network.
Oh, here, yeah. Well,
Test.
testing. Thank you so much, everyone, for attending this event. This is our inaugural HIV Aging Forum, Aging with HIV, Strengthening the Circle of Care. And to begin our program, we would like to start with a land acknowledgement with Patrick Roberts. Patrick Roberts. Thank you so much.
Hello, everybody. My name is Patrick Roberts. I am a clinical research associate. I work at Vitalant Research Institute, which is based out of San Francisco, California, and I'm here to give the land acknowledgement for today. So we begin by honoring the land in which we gather today, the traditional and ancestral homelands of the Cheyenne, Arapaho, and Ute nations, as well as 48 other Native nations with deep, enduring ties to the land that we now call Colorado. As we recognize and give thanks to Indigenous people who have stewarded this land for generations, we continue to do so with strength, wisdom, and resilience. This land is not only the site of memory, but is a living home of Native communities whose contributions continue to shape both past, present, and future. As we gather here today for today's forum, we acknowledge the ongoing impact of colonialization, genocide, and forced removal. We also recognize that the systems in which we work, including government, healthcare, academic, and cultural institutions, were built upon and often continue to enact the exclusion and erasure of Native Indigenous people. With humility and deep impact and respect, we honor the elders both past, present, and also for future, and express our gratitude to the Native communities who continue to share this land with us. May this acknowledgement not only serve as a gesture alone, but as a commitment to listening, learning, and working alongside Indigenous communities to dismantle the legacies of oppression and build a more equitable future. Again, my name is Patrick Roberts. I'm an enrolled member of the Hopi Nation. I'm from the village of Shamopavi, which is in Arizona, on the Hopi Nation. My mother's last name is Lomidofsky, and she passed on her legacy to me. I'm part of the Sun Forehead clan with the Hopi Nation. I'm deeply honored to be here today to offer these words of wisdom and hope to you. I know today's sessions are going to be very meaningful and impactful, so I'm very excited to be here, and I want to thank Erin for allowing me to be here, and we look forward to today. Thank you.
Thank you so much, Patrick. And next, our keynote is from Jeremy Martinez. Jeremy is the Healthcare Access Unit Supervisor and State Drug Assistance Program Coordinator with the Colorado Department of Public Health and Environment. Great.
Thank you. All right, good morning, everybody. Thank you from the bottom of my heart for standing with me to address a deeply important yet frequently overlooked facet of public health, the journey of aging with HIV. This is not just about numbers or medical jargon, it's about human stories, the resilience and persistent struggles of our friends, neighbors, and community members who live daily with this reality. It is a conversation we cannot afford to sideline, It demands our full attention, compassion, and immediate action. Our community's strength lies in our willingness to face issues openly and passionately, ensuring no one is left behind or forgotten. For countless years, the story of HIV has been defined by its turbulent beginning, a time marked by overwhelming fear, relentless uncertainty, and heartbreaking loss. Yet, while we must honor the pain and profound lessons of those dark days, we cannot remain shackled by the past. Today, HIV is no longer a death sentence. Thanks to the incredible advancements in treatment and prevention, people living with HIV are rewriting their destinies. They are not just surviving, they are triumphing, flourishing, and celebrating longer, richer lives than ever before. Let us hold on to hope and remember that progress is possible, and every life impacted is a story of resilience and renewal. However, this progress brings forth new challenges, introducing complexities related to aging with HIV. You may wonder, what makes Colorado unique in this context? Colorado faces particular circumstances that heighten the issues associated with aging with HIV. We have an expanding aging community, an influx of individuals moving to our states, and diverse communities with varying access to healthcare and support services. When we combine these factors with the specific challenges faced by those aging with HIV, we have a situation that requires our immediate attention. As of December 31st, 2024, 54.8% of people living with HIV in Colorado were aged 50 or older. Based on those trends, it is projected that in 5 years, it will be 63.7%, and in 10 years, that figure will increase to 73.3% of people living with HIV will be 50 or older. So let's examine the realities of aging with HIV. Let's consider individuals diagnosed in their 20s or 30s, early in their careers, building relationships and planning for the future. That initial shock and societal stigma associated with such a diagnosis can be difficult to comprehend. Over time, these individuals may face lifelong treatment, manage potential side effects, and address the emotional and psychological challenges of living with a chronic condition. These individuals, our pioneers, have fought relentlessly to stay alive, contribute to their communities, and advocate for meaningful change. They exemplify resilience and serve as living testimonies to the power of medical innovation and determination. Yet as they confront dual challenges, the natural aging process compounded by the long-term effects, Yet, as they age, they confront dual challenges, the natural aging process compounded by long-term effects with HIV and its treatment. So what are those long-term effects? They include an increased risk of cardiovascular, kidney and liver diseases, as well as osteoporosis. Additionally, we observe cognitive decline, depression, and anxiety, alongside the cumulative impact of prolonged medication usage. It is also critical to consider the mental and emotional burdens, the continuous stigma, the fear of disclosure, relationship challenges, and the constant awareness of their HIV status. Moreover, these individuals often face distinct social and economic obstacles. Many have encountered discrimination in employment, housing, and healthcare. Some have lost loved ones to HIV, which can lead to feelings of isolation. Others may battle financial insecurity due to the high cost of medication and healthcare. It is also important to acknowledge that some may experience ageism within their community, feeling overlooked or forgotten as new generations emerge. So, what can we do? What concrete steps can we take to meet the needs of individuals aging with HIV in Colorado? I believe in a multifaceted approach that focuses on the following areas. 1, improving access to comprehensive healthcare. Ensuring all individuals living with HIV in Colorado have access to high-quality, affordable healthcare is paramount. This must encompass not only HIV-specific services, but also age-related care, mental health resources, substance use treatment, and preventative care. We should expand telehealth services, especially in our rural areas where specialists may be limited. Healthcare providers need training to meet the needs of older adults living with HIV, guaranteeing they receive age-related, evidence-based care. Advocacy for policies that expand Medicaid and Medicare coverage, reduce prescription drug costs, and uphold access to affordable health insurance is crucial. Healthcare is a fundamental right that must be accessible to all in Colorado. Healthcare is a fundamental right that must be accessible to all in Colorado. 2, addressing the social and economic impacts of health. Healthcare cannot be discussed in isolation from social and economic factors affecting health outcomes. Issues such as poverty, housing instability, food insecurity, and social isolation profoundly influence the well-being of individuals aging with HIV. We need to invest in programs that provide affordable housing, nutritional support, transportation, and job training. Furthermore, creating opportunities for social connection and community engagement is vital to reducing isolation and fostering mental well-being. Tackling stigma and discrimination that continue to affect individuals living with HIV is essential to building a more inclusive society. This involves public education, challenging discriminatory practices, and elevating the voices of those living with HIV. 3, supporting research and innovation. Ongoing investments into research to better understand the long-term effects of living with HIV and its treatment on aging is necessary. We need to develop new therapies tailored to the needs of aging adults living with HIV. Exploring the benefits of interventions like exercise, nutrition, and mindfulness to enhance the health and well-being of individuals aging with HIV is also important. Collaboration among researchers, clinicians, and community members is vital to ensuring that research remains relevant, ethical, and impactful. 4, and I think is the most important, is empowering people living with HIV. Crucially, we must empower individuals living with HIV to take control of their health and well-being. This involves equipping them with information, resources, and supporting the necessary information, This involves equipping them with information, resources, and support necessary for informed decision-making. Promoting self-management strategies such as medication adherence, healthy eating, and regular exercise is essential. Encouraging participation in support groups and advocacy efforts will connect them with others who share similar experiences. Lastly, we should celebrate their resilience, strengths, and contributions to our communities. People living with HIV are not merely victims, they are survivors, leaders, and advocates deserving of our respect, admiration, and unwavering support. I recognize that this is a significant amount of information, and many of you may wonder, what can I do as an individual to make an impact? I assure you that every one of you has the capacity to affect change. Begin by educating yourself about aging and HIV. Learn the facts, dispel the myths, and share your knowledge with friends, family, and colleagues. Consider volunteering at a local HIV organization to support individuals living with HIV. Financial contributions to organizations improving the health and well-being of those aging with HIV can also make a difference. Advocate for policies supporting people living with HIV, including enhanced access to healthcare and affordable housing. Stand against stigma and discrimination by promoting inclusion and challenging prejudice. Hear the powerful voices of those living with HIV. Their stories are echoes of hope, resilience, and truth that demand to be heard. Their challenges are not just statistics, they are heartfelt calls for understanding and compassion. These individuals are the true experts of their own lives, and their voices hold the key to meaningful change. We must listen with open hearts and unwavering commitment. Again, this is more than just a medical issue. It's a profound humanitarian crisis that touches the core of our humanity. It demands our collective love and responsibility to nurture, to protect, and to stand beside every person fighting to live with dignity, health, and joy. We are called to act to ensure that no one is left behind in their journey through life. Colorado possesses a beacon of hope and innovation. We have the power to lead, to forge pioneering solutions that shine as a model for the nation. But we cannot do this alone. It is only through the strength of unity with our healthcare providers, researchers, leaders, communities, and individuals, the true tapestry of compassion, that we can make a lasting impact. Let us rise fiercely to this challenge. Let our hearts ignite with passion and resolve. Together we can create a future where every person aging with HIV in Colorado is honored with respect, unwavering support, and the opportunity to live fully and beautifully. This is our moment. Let's transform hope into action. Let's turn this calling into a reality. Together, we are unstoppable.
Thank you so much. I just want to share a few words before our next speaker. I think as we come together from across both sectors of HIV and aging, it's really essential that we examine the intersections of ageism and HIV and how language and assumptions shape care, policy, and experiences. So, with that said, I'm pleased to introduce Phil Nash, a longtime advocate and educator who will be speaking to ageism and HIV. Thank you.
Okay, has anybody in the room experienced ageism? Whether you're young or old or in between? Okay, I guess I got something to talk about that you can all relate to. I just want to start with an anecdote that kind of maybe encapsulates some of what we're going to talk about today. I'm just thinking of a friend, a gay man who learned that he was HIV positive after his partner died in I think 1984, the very early part of the AIDS epidemic. So I remember he got tested when tests became available. Anybody remember when tests were not even available yet? Yeah. Okay, when tests became available, he found out that he was also infected with a virus. But somehow he stayed healthy and managed to get to the mid-1990s. I remember going to a New Year's Eve party at his house where he said, "I really would like you all here because this is the last year I think I will be alive." Fast forward 30 years, he's still alive. And now he was told just before the COVID pandemic that he had 2 or 3 months, maybe as much as a year to live because of a congenital heart failure issue that had been discovered. And fast forward another 5 years, he's still alive. So who gets the chance twice in a lifetime to be told you're about to die, and then you just keep on going? Imagine what financial planning and what any of these, planning vacations, like, you sometimes have to book vacations a year out or whatever. Just think of the existential crisis that someone like that is living through all the time. So we're thankful he's still alive, but boy, oh boy, that's quite a roller coaster of a life, don't you think? I don't have HIV, so I am not the kind of expert that some of you in the room who have HIV are. I'm going to focus more on ageism, which I know a little bit more about because at the end of my go to work every day career, my last real job was in the field of anti-ageism with a group called Boomers Leading Change. It was essentially an organization that said, we're going to push back on ageism by showing that older adults who have many skills and many great life experiences still have something to contribute to society, and we're just not going to talk about it, we're going to demonstrate that. So I left that job about 5 years ago, and that work is still going on, although the organization is no longer. We were a little ahead of our time, I think. So this is what we're going to be talking about a little bit today. And so who would agree with me that ageism is the last acceptable prejudice? Who thinks it's something else? Well, Sizeism. Yeah. Well, so ageism was coined in 1969 during my lifetime, about the time that I was in college, by a guy named Robert Neal Butler, to describe discrimination building on the terminologies of racism and sexism. And a few years later, people said, but it's not just a one-way thing. Ageism isn't just about younger people discriminating against older people. It also goes the other way, that there are ageist kinds of prejudices that exist by older people about younger people. But today we're really talking about older people, so I hope you younger people don't feel excluded, and if you do, speak up. So ageism is a combination of three connected elements: negative attitudes toward old age and the aging process, discriminatory practices against older people, and institutional practices and policy that perpetuate stereotypes about elderly people. The ageism philosopher Ashton Applewhite, is anybody familiar with Ashton Applewhite's work? Yeah, she wrote a book called This Chair Rocks, and she has a podcast and a website. But she said ageism is prejudice against our future selves. Does that resonate with folks? Okay. So as we get started on this conversation, I was asked to engage you all in some questions. So the first question for you to talk about for a few minutes at your tables this morning is, have you experienced ageism in your own life? And here are some questions that may pertain. So I just send it back to you, to your tables, to speak up, and we'll come back together in 2 or 3 minutes. We'll wrap up here in about 30 seconds. Okay, let's move on. I hear a lot of chatting. I'm glad to hear that this question provokes some thinking and some discussion. Does anybody have any really unexpected or wild or interesting observations at your tables that you want to share? No? Okay, we'll just move right into the next thing. I'm going to talk about the reality of aging in today's world. Now, this isn't today's world. This is my world when I was a kid. That's the cutest kid there is the one in the middle, and that's me. And that's my grandmother. My grandmother is 63. Is that what 63 looks like these days? Yeah. No, my grandmother was severely diabetic, and she also had serious depression. I learned much later in life because we didn't talk about those things when I was a kid. When my grandmother was born in 1892, I looked it up online. Her life expectancy, if you take out infant mortality, if she got beyond 2 years old or 5 years old or whatever, her life expectancy was 59. But she actually outlived her life expectancy. She died at 67 years and 51 weeks in 1960. I was very lucky. I grew up in a family. I was around old people from a very early age, and I loved my great aunts. I knew 2 of my great grandparents. I knew 3 of my grandparents and was deeply loved by them, and I loved them, and so forth. Now, I was born in 1950. My grandmother's 3 oldest sons had their first child. They and their spouses had their first child in the summer of 1950. My cousin Marilyn, who is down on the lower left, then me, and then my cousin Dwight, who's just 2 months older than me. Sadly, we lost Marilyn about a month ago. She passed away. Dwight and I are still cooking along. Our life expectancy at birth was 66.5 years, and I've done as well as my grandmother. I've lived about 8 years longer than my expected life expectancy at birth. And again, 5 years more for white women. But that reality has changed significantly because in the future, most children born in prosperous nations today will live into their 90s. And 85 plus is now the fastest growing age demographic. And if we look at the number of people who are living to 100 and beyond, the year I was born, there were 2,300 people over 100 years old or over in the United States. Today, that's 101,000, and in 2054, when I expect to still be around, there will be 422,000. We cannot afford ageism with those kinds of numbers. We cannot afford to tell people at age 50, 60, 70, go away now, you're no good to our society. So I did not get deep into ageism and HIV, but there's plenty of material out there about HIV and ageism in healthcare. So just examples of overt ageism in the healthcare system: exclusion from treatment, ineligibility for certain procedures or treatments based on age alone. The person that I described earlier who has faced who thought he was going to die twice now, the only remedy for him was a heart transplant in this most recent episode. The team that decides those things said, no, you're not going to get a heart transplant. And HIV was a factor and age was a factor. Prioritization based on age during crises, during the recent COVID crisis. Anybody who was above a certain age got points off if healthcare had to be rationed, because the experts said, well, we know you aging people, we know, how much longer you're going to live, and just look at the data. So didn't matter what health status was. Age was considered a demerit in the rationing of healthcare in scarcity situations. And then dismissing concerns. That's normal for your age. That's normal for your age, and therefore potential misdiagnoses and so forth. Lenny, did you have a question, or did you have something to say?
So these statistics are all based on the United States, is that correct? Their numbers, the previous.
Oh, the previous slide?
Yeah, all United States or just?
That's U.S. numbers. U.S. numbers. Yes, that's correct. We need to take into account that, and I said something later or earlier, in prosperous nations, children born today will be, in prosperous nations, they'll live into their 90s. The United States is still a prosperous nation. Haven't looked at the stock market today, but
That's actually not correct, because when we look at kids who are born on Medicaid, 25% of children who are born today receive Medicaid services, and with the cuts that we're talking about at the federal level, I would argue that that's something we need to be worried about today even.
okay. I'm not an expert, so.
No, it's fine, I just wanted to put that out there, because we were talking about prosperous nations and stocks, and I think we need to bring in a lot of the inherent challenges that are in today's modern reality.
Thank you. So there is more implicit ageism that's really what is called unconscious bias. Elder speak, condescending language used in the healthcare environment. Honey, sweetie, young man. I get young man a lot. Reduced communication. When somebody goes to the doctor with a caregiver, the doctor speaks to the caregiver instead of to the patient, which is dismissive. Underestimation of abilities, low expectations from older adults. They can't do this, or they're incapable, they're not really interested, they won't follow through. The assumption of cognitive impairment. I think cognitive impairment needs to be a consideration, but it's not a given, and most people are not cognitively impaired, most older adults. So treating older adults as if they have cognitive deficits or just a little slow. And then the lack of participation in research, excluding or ignoring older adults from clinical trials. Therefore, medicines that are developed and given to older adults, we don't know what the impact is. We do know the impact. They do this for children, they don't do it for older adults. So let's talk, I'm looking at the time here. Another question for the table. With regard to aging and ageism, what negative or positive experiences have you experienced in the healthcare environment? As a person with HIV, as a healthcare provider, as a patient, providing constructive feedback, and so forth. So you can see the questions there. Go at it and continue your conversation at the table for, let's say, 2 minutes. 2 minutes. We'll wrap up here in about 30 seconds. Okay, let's come back to whatever we're coming back to. I just wonder, does anybody have at their tables an example of a positive experience in the healthcare environment related to, yes,
I started my transition at age 69,
yes,
and I had to fight Medicare, and thank goodness I have a wonderful PCP at Denver Health, who had to go all the way to administrative judge. You know, they'll give you a vagina, okay, but to get breasts and facial feminization, oh, you're too old for that. But we won, again, because of my wonderful PCP, Dr. Hoffman, Denver Health. So yes, I had quite a bit of struggle.
but you had to fight really hard and go to court.
Yeah, well, administrative hearing with Medicare.
Administrative, well, okay.
They finally approved it, so
Congratulations. Congratulations. Let that be an inspiration. Do you have,
I've had, let's put it this way, I've had probably about 7 or 8 operations due to health reasons at Denver Health. 2 of them for my, 3 of them for my eyes, 3 or 4 for my kidneys, and 2 heart attacks. I had to go to my arthritis to enter angioplasty for a stent. So they write, you know, even though they got you positive and over, they like that. Telling you I
well, thank you.
nerves, I said, God ain't ready for me yet. Heaven ain't ready for you yet.
Well, thank you for that story. Okay. So the thing that a group that I've been involved with is Changing the Narrative Colorado. Maybe many of you have been touched by the messages from my partner in crime, Janine Vanderberg, who was very much part of helping found Boomers Leading Change, gosh, back almost 20 years ago, onto a new venture she created. This is an incredibly helpful resource. They have done initiatives on healthcare and education and many other things. So I really highly recommend the website, Changing the Narrative Colorado, changingthenarrativeco.org. So, becoming educated about ageism, you're here today, I don't have to convince you of that. Examining your own assumptions, attitudes, and actions, and also recognize internalized ageism. Is that a new term for folks? Do you know what internalized ageism is? I discovered internalized ageism after thinking about internalized homophobia. So you internalize early in life, you learn how gay people are bad, it's sick, sinful, and against the law. That's what was taught to me when I was growing up. So I had this internalized bias against gay people, and then, oh my gosh, I'm one. So you're stuck with those internalized impressions. Well, if you grow up not liking old people, and then what the heck, you become an old person, you've internalized a lot of stuff that is self-prejudicial. Learn about how ageism, both systemic and internalized, negatively affects health outcomes and the healthcare system, and avoid basing assumptions about a person's health status and functionality or your own as a patient on age alone. And in communicating with older patients, respect their autonomy, speak to them first as to a caregiver, and to a caregiver if you were directed to do so by the patient. So one final table question. How can you and I challenge ageism starting today or tomorrow? And do we have time? 1 minute. Okay, it's time to wrap up again. How many of us use terms like I'm still able to fill in the blank? Are you still doing fill in the blank? Just the word still is sort of an implicit ageist attitude. And I find myself doing it all the time. So anyway, the bottom line here is that thanks to the work of Becca Levy, who the work was shared by the organizers here today, she's determined, or through her research, she has found out that thinking positively about aging can add 8 years to your life. Or if you think in reverse, if you have negative thoughts about your own aging, it kills you off 8 years earlier. So age beliefs, it turns out, can steal or add nearly 8 years to your life. In other words, these beliefs don't just live in our heads. For better or worse, those mental images that are the product of our cultural diets, whether it's the shows we watch, the things we read, the jokes we laugh at, the greeting cards that we see in the stores that starting at about age 40 let you know that you are, quote, over the hill, end of quote, become the scripts that we end up acting out. And that, thank you, Becca Levy. And just one final thing. We live many lives in our one lifetime. Think about on your way home today, we're all aging, so as a person who is aging, what do I miss that I had at an earlier age in my life? What do I have now that I cherish that I couldn't have had when I was younger? And what do I look forward to as I get older that I don't have now? So, thank you very much for your attention, and have a great day.
Thank you so much, Phil. So as we continue to explore the intersections of HIV and aging, it's important to ground our discussion in a shared framework. So this next panel will do just that, laying a foundation for our sessions ahead by using the geriatric 5 M's. Is anyone familiar with the geriatric 5 M's? Not the speakers. It's not fair. So we'll be addressing 5 domains of the geriatric 5 M's. That's multi-complexity, mentation, mobility, medication, and what matters most. So we're honored to be joined by a panel of experts to bring deep insights and experience to this work. Beginning is Dr. Ali Abraham. who will speak on multicomplexity, followed by Dr. Jacob Walker addressing mentation or cognition, Dr. Christine Erlandson, who will be focusing on mobility, Dr. Charlotte Richetti, discussing medication polypharmacy, and finally, Elaine Doherty, highlighting what matters most in the lives of older adults living with HIV. We're very excited for their expertise and look forward to this critical foundation. And starting is Dr. Ala Abraham.
Let's push this forward. Good morning, everyone. I hope everybody had their coffee. We're going to need some excitement here in this room, I think, because we have such an excellent panel of aging experts. I'm going to kick us off, and I'm just so pleased to be here with all of you, sharing in this moment to talk about aging and HIV. So what I'm going to do is a brief introduction to the geriatric 5Ms. I'm going to talk a little bit about the concept of multi-complexity, and then I'm going to talk to you about something that's sort of a passion of mine, which is sensory loss and how that really plays into multi-complexity. Okay, so the geriatric 5Ms, if you haven't heard of them before, are really principles for care as we age. So we're all living, this is the good news, longer, healthier lives, as Phil showed us. But despite that, as we age, many of us will acquire health conditions, health concerns. We may experience changes in abilities. And that just means that our health care becomes more complex as we age. And in addition to that, the priorities we have around our health may change as a result of our relationships, our experiences. So the geriatric 5M, it's really how providers focus on these 5 key areas known as the 5Ms. The M stand for the targets that are important for care as we age. So we have the mind, right? So what about your cognitive health? That's something that we all think is important. We should think about in our care. Our mobility. How do we get around? How do we get to the places we want to be? How do we continue to do the things we want to do? Medications. As we acquire various conditions, they may require medication or treatment. And how do we balance the burden of those medications? How do we look at the interaction of those medications and treatments? What matters most? We may have different priorities around our health. What are the things we really want to focus on and work on? What are the things that maybe we want to take sort of a watchful waiting approach? And then finding multi-complexity is just the umbrella that speaks to the interaction amongst all these things. So multi-complexity really describes sort of the whole person, their health conditions and their biopsychosocial needs. So we're going beyond just the mere fact, the presence or the absence of various comorbidities, to think about sort of the holistic interplay between all these various factors impacting an individual's overall well-being and their ability to navigate their lives, their ability to access care, and their ability to thrive. Okay, so now I'm going to talk about sensory health and try to convince you that it really plays a deep role in this multi-complexity idea. So first, I think I have to convince you that it's actually a burden. Is this really a problem in aging adults? And I would argue absolutely it is. As we age, many of us are going to experience sensory loss of some sort. And I'm going to focus on hearing loss and vision loss, but I don't want to diminish the impact of loss in other senses. People experience loss of changes in their taste. They experience difficulty with feeling, their perception due to neuropathy. So there's lots of ways we can experience sensory loss, but I'm going to focus on vision loss and hearing loss. And to show you this graph that's on your left, I had to turn that direction to make sure I had the right direction. You can see this is data from the NHANES survey that just shows the prevalence or the burden of vision loss in various age groups, so as we age. And you can see that arrow showing that it sort of starkly increases across the age groups. But I want to make a note that this represents really a very narrow perspective on vision impairment. It only speaks to vision impairment that has to do with how well
You can recognize faces or read signs in the distance. And for many of us, we know that there's lots of other types of ways that we experience vision impairment. You may have difficulty navigating stairs in a dimly lit stairwell, or for those of you who experience glare like I do, maybe you've had difficulty with night driving, right? So there's lots of different ways that we can experience vision impairment. This is a very narrow view, and yet you see that in our oldest age groups, over a quarter of people are experiencing this narrow perspective of vision impairment. So that's a big burden. That graph then on your right shows the projections of how the burden of vision impairment and blindness is doubling between 2015 and 2050. So we're going to see so many more people who experience vision impairment and various eye conditions such as glaucoma, cataract, diabetic retinopathy, age-related macular degeneration. And this is going to have an impact on their functioning, their daily lives, but also society in general is going to feel this impact. Okay, so hearing is the same story. As you can see, we're going to have, an increasing burden of hearing impairment as we go through the age groups. You're seeing higher levels of hearing impairment. And again, just like vision, hearing is complex. So this just speaks to what we call peripheral hearing loss. It's really how the ear itself functions, all the machinery in the ear. But many older adults experience different kinds of hearing impairment. They have trouble with noisy environments. So they'll say, I hear pretty well in a quiet room, but if you put them in a noisy environment, they really have trouble sort of decoding or interpreting what their conversational partner is saying to them, right? So that's a problem with auditory processing, and that is not represented here. So again, this is sort of an underrepresentation of the burden we really have of hearing impairment. But still, what you see is in the oldest age groups, 8 out of 10 people are experiencing what we consider peripheral hearing loss. For people aging with HIV, why this is even more relevant is the data seems to suggest that there are various types of hearing loss, various types of vision loss and eye conditions. They're just more prevalent in adults aging with HIV. So this becomes even more relevant for this population. Okay, so why is sensory loss related to multi-complexity? So I'm going to give you a couple different reasons why I think it sort of interweaves into this idea. So the first is that sensory loss really impacts all of our domains of functioning. And what do I mean by that? I mean, if you have sensory loss, it's just more difficult to get out and be physically active. It's hard to get out and navigate your environment. If you have sensory loss, you may have trouble getting to sort of the social spaces in our community to interact with your friends and your neighbors. You may experience some depression, so your emotional well-being is impacted by your sensory experience. And then finally, your cognitive health. So sensory loss has an impact on your cognitive health and your risk for cognitive decline. So those are all sort of these direct effects. And for people aging with HIV, they have more susceptibilities to some of these losses of functioning. So it may be even more relevant. The second piece of this is that it impacts our ability to access care and engage in care. It may make it harder for you to read the tiny instructions on your pill bottle or to really absorb complex health information from your provider or even to get to your medical appointments. So we've done a little work here, and we found that for a group of men who were aging with HIV and they reported vision difficulty, those individuals tended to also report lower adherence to their HIV medications and also skipping necessary medical care. So really showing that this does have an impact, particularly for populations who have more complex care. Okay, and speaking back to that point about sort of direct effects, I want to focus on one outcome that I think is really relevant for all of us, which is our cognitive health. It's sort of one of those things we worry about as we age. So this is from the Lancet report on dementia prevention, and they've put this out a couple times, but the most recent one was in 2024, so just came out, and it sort of summarizes the current evidence around risk factors for dementia. And as of 2024, both hearing loss and vision loss are included amongst the 14 top risk factors for dementia across the life course. Right? So what does this say? It says that sensory health really is cognitive health, and we have to be really aware that optimizing our sensory experience also means reducing our risk for bad cognitive outcomes. And I think the final piece here to multi-complexity is just how various factors sort of interact with our other health experience, impacting the final outcomes we experience. So do you have this interplay between different factors? And certainly that is true for sensory loss. So this study sort of showed that. The authors reported having both a visual impairment and a comorbid health condition was associated with the greatest limitations in physical functioning and participation, and the likelihood of experiencing worsening health during the previous 12 months, right? So sensory loss has direct impacts on these outcomes of aging. It also impacts our ability to access and engage in care. And finally, it makes the other health conditions we experience worse, amplifying their effects. And lastly, just dipping into one of the other M's, what matters most, it turns out that vision and hearing are important for people. So this is from the 2021 Colorado statewide coordinated statement of need on HIV/AIDS prevention and care. And 21% of the adults surveyed reported that vision issues were one of the key non-HIV health concerns for people aging with HIV. So this is really an important issue for people. People value their vision, they value their hearing, and I just want to speak a little bit to the ageism piece. I often hear people say, I see pretty well for my age. I hear pretty well for my age, that internalized ageism. But we all deserve the best vision and hearing experience that we can have, not only to reduce our risk of various outcomes, but just because vision and hearing are how we navigate our world, right? They're really important for our quality of life. Okay, so I'm gonna end there and turn it over to the next speaker in our fabulous panel, but I just want to make the note that the bulk of vision problems that people who are aging experience are either correctable or certainly treatable. And most of the hearing loss that people experience can be mediated or remedied with hearing aids, right? We can improve our vision experience, we can improve our hearing experience. Why not do it? Let's have the best hearing and vision we can so that we really maximize our quality of life. Thanks.
All right, let's keep things moving. So I'm Jacob Walker. I could talk about mentation for hours and hours, and I only get 10 minutes. So I'm going to breeze through this, highlighting that mostly what I'm going to be talking about is cognitive impairment, noting that depression, anxiety, loneliness, and isolation, as Dr. Abraham mentioned, are also extremely important to our quality of life and well-being as we age. Take a moment to remind ourselves that it is normal to experience some problems with cognition as we age, minor problems with memory and processing. So let's all cut ourselves some slack and celebrate that we've made enough friends to forget some of their names. It is okay. So I hear this all the time, like, oh, I can't remember their name, or oh, what's that word on the tip of my tongue, or where did I put my keys? That's okay, that's normal. Normal aging change, or normal memory changes with aging, however, should not impact day-to-day life. When they do start to impact day-to-day life, that's when we start to worry about dementia, which is usually what people are talking about when they're talking about the M of mentation. Dementia is more common as people grow older. It is not, however, a normal part of aging. We should not all expect to develop cognitive impairment later in life. Dementia is memory loss causing functional loss. So it's when those minor problems start to escalate out of control to the point that they're interfering with our day-to-day lives, our management of our medications, appointments, bills, losing those car keys and never finding them again. You'll often hear dementia used interchangeably with Alzheimer's disease, which is the most common type of dementia. Now, when most people hear dementia or Alzheimer's disease, they think memory loss. Like, I just cannot remember anything. And it's worth noting for ourselves that cognitive impairment comes in a lot of shapes and sizes. It's not just memory loss. Sometimes it's difficulty with organization, judgment, changes in mood or personality. Sometimes it's more of a processing difficulty. We just can't think as quickly as we could, or we have trouble with spatial awareness, images, or language. I had a patient who was a mathematician, and he was like, the first thing I noticed is I was struggling with math, and that's my whole thing. So it can come in a lot of shapes and forms. Keep an eye out for some of these early signs if you're worried about your own memory or the memory of someone else that you know. Now, as the community of people living with HIV gets older and older, they are more likely to experience dementia. Again, age is the most common risk factor, and Alzheimer's disease, the most common type of dementia, is still the most common type of dementia in people aging with HIV. People with HIV, however, may be at an even higher risk of Alzheimer's disease than same age peers due to the higher prevalence of some of the risk factors listed on the right. So higher rates of tobacco use, more heart disease, more isolation and loneliness, more depression, more physical inactivity. These are shared risk factors for Alzheimer's disease that are also more common in people living with HIV, which makes the rate of cognitive impairment higher in folks living with HIV as they age. If that weren't enough of a bummer, people living with HIV are also at risk for HIV-associated neurocognitive disorders, or HAND. HAND ranges in severity from very mild to very severe. In the era of HIV treatment and antiretrovirals, we see severe HIV-associated neurocognitive disorders, or what used to be called HIV-associated dementias, very infrequently. As a geriatrician and an HIV specialist, I should be like the doctor in town that sees all of these cases, and I can count on one hand how many people I've seen with a true HIV dementia in the 2020s. However, mild HAND is very common. Estimates range between 20 and 30% of people aging with HIV experience some amount of very mild cognitive impairment. These features include slowed thinking, trouble concentrating or maintaining attention, sometimes some mood changes. Memory loss can happen, but is usually not a core feature of HAND, unlike in Alzheimer's disease. I see a few nods as I'm going through these lists of symptoms. So people will often describe to me like, yeah, I'm very functional. I can still think straight. I can still remember everything you told me, but man, I just cannot solve a problem as fast as I used to be able to, or it just takes me a minute longer. Some of the risks for developing HAND are low CD4 counts, untreated HIV and cardiovascular disease, as well as substance use. We see it most often in folks who, for one reason or another, had to go a very long time without any treatment for their HIV, are more likely to experience HAND later in life. Again, on the spectrum of cognitive impairment, HAND is very broad, can run the gamut from mild to severe, but most falls in this mild cognitive impairment category. It does not lead to functional loss. We have a hand. Don't let me forget. All right. If you are worried about cognitive impairment in yourself or in a loved one, just some quick tips. It is good to start with a visit to their doctor. Attend visits with someone you're worried about, take notes, ask a friend to come with you if you're worried about yourself. Bring a full list of medications. Again, this goes back into that internalized ageism. Like, don't assume all memory changes are dementia or that someone is developing memory changes just because they're old. Seek guidance first. Part of why, and I'm a doctor recommending to see a doctor, but part of why is that diagnosing dementia is really hard. It's like what I do all day, and it doesn't get any easier the more times you do it. It requires a really thorough examination of the person's past, person's symptoms, their past, their physical exam, formal memory testing, often brain imaging, like the MRI here on the right. It may require the input of experts in neurology or geriatrics. Making it even harder in the world of HIV care is that HAND is a diagnosis of exclusion. Early HAND can look very similar to Alzheimer's disease, and it's tough to tease out what we're seeing, but it's important that we do so we can better guide people on what to expect for themselves in the future and how to manage their cognitive health. But I want to end with some positives here. I will tell folks that I'm seeing in clinic that this always makes me sound a little bit of either a broken record, the doctor saying take an apple a day, or a little bit hippie that I'm not recommending medicines. I'm recommending socializing, exercising, and healthy diet. These are the things that have the most evidence for slowing and preventing cognitive decline in anyone. Added to that is consistent HIV treatment for people worried about hand. Staying social. If you had some chit chat over breakfast this morning, pat yourself on the back. You're doing what you can to prevent cognitive impairment. If you biked here or walked here, pat yourself on the back. If you enjoyed that healthy breakfast, pat yourself on the back. It sounds so simple, but these are the things that are going to have the most impact on cognitive health in the long run, and are going to have positive impacts on cardiovascular health, on physical function, on sensory impairment, all of the multi-complexity that Dr. Abraham just talked about. And while they sound so simple, they're not what our healthcare system is set up to help manage. So this is where we kind of need all hands on deck to help our older adults socialize, stay active, and eat well. So, in summary, I know it's a lightning round on mentation. Memory loss, again, not a normal part of aging. People with HIV are at a higher risk for dementia and have their own unique difficulty dealing with hand. If you have worries about yourself, it's good to start with a doctor because it takes a village to help people facing cognitive impairment. And you can lower your own dementia risk by focusing on exercise, diet, and socialization alongside HIV treatment. All right, that was a whirlwind. We'll have questions at the end. I'm gonna hand it off to Dr. Erlandson. Thank you.
Good morning, and thank you all for coming. I'm going to move into the next M, which is mobility. And I wanted to start just delving in a little bit more into what we mean by the terms physical function or mobility, and I'll refer to these two terms interchangeably. So physical function or mobility can span a wide range of different activities, from whether someone needs assistance with bathing and eating and kind of those day-to-day things to function, to how well they can walk on a very brisk walk or whether they ran 5 or 7 miles to get here today. So just a very wide range of what we mean by physical function. And how do we assess physical function or think about how someone's doing? This can also be a lot of different measures. So it could be how fast someone can walk. It could also be how people walk. So does someone kind of stagger across the room or have a lot of difficulty in turning, really seem to have a difficult time starting to walk? How fast can they get up from a chair, or can they even stand up from a chair without using their arms or grabbing onto something to push themselves up, which can tell us a lot about how someone's leg strength is. What's your grip strength? Can you open that jar, or do you need assistance trying to open things or squeeze things? Or just your balance. So could you stand on one foot for 30 seconds and be able to stand up without falling over? We can also just ask, are you having difficulty in walking a block or walking a mile? Do you fall a lot? Have you fallen several times since your last visit, which you may get asked when you go into the doctor's office? Or could you do you have any limitations in your daily ability? Do you have a hard time taking a shower because of concerns about balance in the shower? We've been interested in how to assess physical function in our clinic at the university, and I know you'll hear a little bit more about this later from Aaron's group, but we've been using this gait speed device in our HIV clinic at the university, modeled from something that the seniors clinic that Jacob works with is using. And this attempts to look at how fast someone can walk when they're coming into their clinic visit. So you get your blood pressure, you get your pulse, you get some of those other vital signs, your weight, your height, and then you walk past these two sensors, and we can also put in your chart what your gait speed was that day. So that way it goes in your note for the day. Your provider can look to see if your gait speed changes a lot between visits, because we think this measure is really important, and I'll tell you a little bit more as to why. So this figure you may have seen previously if you've heard me talk before, because I think this is a really important figure. But this kind of shows us in the general population what we can learn just from someone's walking speed. So if you see that top arrow on the green line, this tells us about how long we think someone can survive only based on how fast they walk. So someone at age 70 who has a fast gait speed of maybe 1.6 meters per second, so pretty brisk walking speed, we expect to live about another 30 years. In contrast, someone who's walking really slowly, you can kind of picture them barely making it across the street when they're trying to hit the stoplight and wait for the walk signal. That person maybe has 10 years of life left. So just how fast someone can walk can tell us so much about their longevity, whether we need to do some of those extra cancer screenings, or whether we need to start talking about home health care. Gait speed and physical function and other measures of mobility are a major predictor of independence, whether someone can continue to live independently at home. It's also associated with falls, broken bones, and lots of other medical conditions like diabetes or heart disease. A lot of researchers and clinicians have thought that using walking speed or some of this gait speed measures as a vital sign may actually be more helpful in clinic than your blood pressure or how much you weigh or some of those other measures that we do. So the big question is, do people with HIV have more impairments in their mobility or their physical function than people without HIV? Dr. Abraham mentioned a study of men with HIV, and we looked at this question in that study. So it includes men with HIV and men without HIV, and it's called the MAX study. This has been in existence back since the 80s, and we were able to look at how gait speed and grip strength, two measures of mobility or a physical function, change over time. And in the top blue line, you can see how quickly a gait speed changes over time in men without HIV. And the red line shows how gait speed changes in those with HIV. And what you can see is that red line in both of these tends to decrease faster, meaning that men with HIV tend to lose grip strength and have slower walking speed over time compared to people without HIV. We also are interested in falls as part of mobility, another thing that we can think about. And in the general population, we think that probably about 30% of people age 65 or older experience a fall in the prior year. We've looked at this across several different kind of large studies of people with HIV, and we see rates even in people that are 50, around 50 years old, very similar to that population of people 60 and older. So in some of these studies, we see up to 40% of people are having to fall over just a 6-month time period. And in some of those studies, those rates are similar even in people who have multiple falls. So really a high risk, not just that one slip on the ice or that incidental dog tripped you with a leash when you were walking, but actually people that keep falling. So really important problem, sets people up for hip fractures, and we know that having hip fractures or other fractures can lead to being in a nursing home or a loss of independent living. So what factors contribute to physical function impairments or mobility impairments in people with HIV? Well, lots of different conditions, and many of these conditions also occur more commonly in people with HIV, as you've heard in a couple of the prior talks. Neuropathy, if you can't feel your feet or can't sense where you're at, you're much more likely to walk slower. Arthritis or chronic pain certainly going to contribute to slowing in mobility, heart or lung conditions, diabetes, in part because of neuropathy, and then we think that that might just impact muscle. Muscle strength, and this could be part of old antiretroviral therapy regimens that might have impact on muscle. Your energy levels. If you don't feel good, you're not going to walk as fast, you're not going to be as active. And then certainly mood and brain function can both have a very important role in mobility. So how do we best improve physical function or mobility? Well, our group has been really interested in how we can improve physical function as people age, but really starting earlier in life. So we obviously want to improve mobility in older people, but how do we keep people aging well throughout their lifespan? And one of the most important things is just to move. So exercise, physical activity, anything that you can do to keep moving is probably the best thing you can do to preserve mobility and to keep high function with aging. For some people, physical therapy or occupational therapy may be an important first start, especially if there's concerns about safety with walking. If you have a lot of pain or other impairments, then a physical therapist can help with balance and stretching and making sure you're safe to exercise. I wanted to mention a couple of studies that we've done at the university. Some of you have been part of these studies. This first one was a study we did several years ago, and we looked at how people with HIV respond to exercise compared to people without HIV. We enrolled people who were age 50 or older who weren't currently exercising, and we had them come into our gym over at the university hospital 3 days a week. On the bottom of this graph, you can see how much people improved over the 6 months of the study. And then on the axis that goes up and down, you can see different tests that we looked at. So we looked at how fast can someone stand up from a chair, how fast can someone walk a quarter of a mile. And if you first look at these graphs, what you see are those two bars look almost the same across each of those. So the red bar and the black bar are almost the same. The red bar is people with HIV, the black bar is people without HIV. So we know that with exercise, people with HIV improve almost exactly the same, if not more, on a lot of those measures than people without HIV. And then the second thing you might see is that people with HIV and controls both improved a lot on some of these measures. So on bench press and some of these strength measures and how fast people could get up out of the chair, we saw about a 40% improvement in these measures in people who weren't exercising, who came in and exercised for 6 months. We just finished up another study, and we haven't published this or presented it yet, but this was a study that we've been doing over the last 5 years, and we were looking at whether high-intensity interval training, so that we heard a lot on the news in the years past about you could just exercise at a short interval, and if you do these interval trainings, you'll have even more improvement. So we looked at a high-intensity interval training versus just getting on the treadmill and walking or running for 45 minutes. And essentially saw that either of these, either high intensity or just continuous exercise, resulted in very nice improvements in physical function. We saw improvements in how fast people could walk and their strength, and it didn't really matter. So it doesn't matter what kind of exercise you do. The most important thing is that exercise works if you do it. And then lastly, I just wanted to put in a quick plug for a study that we're going to be starting enrollment later this month and early next month. This is called the Triumph study, and I put some flyers at the Colorado Health Network table, and then my research assistant's emails down here in the bottom. We will be looking at a drug called tesamorelin, or Egrifta, it's also known as. This is a drug specifically to treat belly fat in people with HIV, and we think that it might have additional benefits on muscle, and so we're going to be using this in combination with exercise to see how this can help improve physical function. So in summary, mobility is a key component of aging. It's so important with how people continue to function and stay able to age in their home. It's mobility impairments are more common in people with HIV, likely in part because of some of the comorbidities that people experience. And movement or physical activity is one of the most important things that we can do to improve mobility with aging. And I just wanted to put a picture in here of some of our study team members. We're doing lots of studies on mobility out at the university, both with Dr. Walker and Dr. Abraham, and we'd be happy to talk to you about any of those if you're interested. So thank you for your time, and I will turn it over to Dr. Ricchetti for medications.
All right, good morning, everyone. Thank you for having me here, and I'm really excited to be with you all this morning. I, too, could probably talk about medications for hours and hours and hours and hours, but I have 10 minutes, so I'm going to try to hit some high-level topics, and hopefully it just generates some discussion throughout the day. When we think about focusing on medications in adults aging with HIV, there are 3 major principles, which is optimal prescribing. High level, what that means is, are we choosing medications? Are the medications impacting our mentation, our mobility negatively? And more importantly, are they achieving the goals of care that we want to achieve and helping us focus on what matters the most? Polypharmacy is being aware of the risks of taking multiple medications and how the more medications can increase risk of side effects, interactions, cost, burden, and then deprescribing when appropriate, especially when these concerns are identified. I think of deprescribing as an ongoing conversation, a two-way street between patient living with HIV, caregivers, the healthcare team, and thinking about what matters most and how do we optimize the medications and reduce the risk for poor outcomes. So optimal prescribing. In adults aging with HIV, this is multifaceted. So first, we're thinking about our antiretroviral therapy. Is it appropriate for the other medical conditions that we're experiencing? Does it need adjusted for kidney function, renal function, liver function? And how complex is the regimen that we are taking or prescribing? As mentioned by some of the previous speakers, comorbidities, as adults with HIV are living longer, there's the higher incidence of normal, common age-related chronic conditions. And due to the inflammation of HIV and some of the therapies, some of these conditions are higher risk in HIV populations or can occur a little earlier. So when picking medications for these, Are there interactions? Are there side effects? And how do we make sure that we're prescribing the most age-friendly medications when possible? Appropriate prescribing might also include immunizations and medications to prevent other infections. Polypharmacy depends on which researcher you're asked on what the definition is. Is it more than 6 meds? Is it more than 10 meds? It's a lot of meds. And I work with some patients and I said, you've got a whole pharmacy here. That's the definition of polypharmacy. The prevalence of adults living with HIV is relatively high, at least 35%. And you can kind of see the exponential growth of that or risk of that as we age. So adults over the age of 65 living with HIV, 93% are probably experiencing some level of polypharmacy. One potential contributing factor to this, not just the number of comorbidities, is something we pharmacists call a therapeutic cascade or prescribing cascade. And that's when we maybe fail to recognize a side effect as causing a symptom, or we're using medications to treat the side effects of another medication rather than take a step back and say, is that first medication needed? Is there an alternative to that first medication? A really common one is someone maybe taking a stimulant to help with their mood and depression, or maybe taking NSAIDs, anti-inflammatories, for their pain, and now they have high blood pressure, and we're treating their high blood pressure, as opposed to thinking some of the alternatives or what could have contributed to that. Many reasons polypharmacy is a concern. I put the top 4 here for you. So side effects, and we'll talk about that a little bit more, but we do know that polypharmacy increases the risk of falls, hospitalization, and even death. In a study of patients, veteran adults who live with or without HIV, there was an increased risk of hospitalization by 47% when they were polymedicated. And it was kind of a dose response. For each new drug that was added, there was an 8% increased risk for hospitalization. Burden. The more meds, the harder it is to stay adherent and take those medications every day. In adults living with HIV, at least 60% report not adhering to or not taking at least one medication for a week or more in a year's period of time. And when I think about burden, it's not just simply the number of medications. How many doses do I have to take a day of this medication? Do I take it with food? Do I take it without food? Do I have to open it and store it? How do I inject it? What are those extra steps that I have to take this medication correctly? All of which, if burdensome, can affect adherence negatively, and most of which are modifiable. We all know the more meds, the higher the cost. I won't go into the way we pay for healthcare, but we just need to keep in mind that we know that cost is a burden. Drug interactions with antiretroviral therapies is huge. It's probably, as a pharmacist, the light bulb where I know there is the most potential risk for drug-drug interactions. In one study, they looked at patients' medications list and found that 75% had at least one potential drug-drug interaction, 7% of which were considered severe. Typically affecting either reduced efficacy of the medication itself or 42% reduced safety, so increased risk of side effects or toxicity. So polypharmacy, we really need to be mindful of what we're taking and what we're prescribing. Focusing on that side effect. So not only number of meds goes up, the more exposure, the more risk that you have to maybe having a potential side effect. But as we age, the risk for side effects also goes up. Our body, the digestive system changes, our gastric pH changes. That might mean that medications hit our bloodstream faster or slower, and then that's going to change the way they act in our body. If there's less water in our system, more fat tissue, which can happen with aging, those medications can build up in our tissues more. They're going to stay around longer. We have higher levels. Kidney decline, liver slowing down means our medications are eliminated slower and they stay in the body longer. So again, higher risk for side effects. And then I'll give it a specific example a little bit later, but there are also incidences where we are just more sensitive to the action of certain medications naturally as we age. I just wanted to give a really simple example that many people are probably already aware of a common drug-drug interaction. Some of the antiviral therapies require a higher level, need stomach acid in order to be absorbed correctly. And so medications that lower stomach acid, we're taking medications for acid reflux, your Prilosec over the counter, your Pepcid over the counter, your Tums, it can actually reduce the absorption of those medications. There are other meds, antiretrovirals, that can bind on to some of the ions that we take, calcium supplements, iron supplements, magnesium, and when those bind together in your stomach, it prevents them from getting absorbed. And so I'm going to use the acid reflux example again. You take the Tums for heartburn, and that can impact the absorption of your antiretroviral therapy. And I don't mean it to scare you, but I think my goal here is just to emphasize when you're starting new over-the-counter medications, herbals, supplements, please talk to your healthcare team. Ask the pharmacist, are there drug interactions? What do I need to know about this? Because often you can time these medications differently, or they'll find one that's appropriate for you to take. Potentially inappropriate medications is another concern with adults aging with HIV, adults aging in general. A potentially inappropriate medication is one where the risks of side effects and harms may potentially outweigh the benefits it was giving us before. And in at least 3 different studies, it was found that more than 50% of adults aging with HIV were prescribed a potentially inappropriate medication. And in one study, that was as high as 70%. Common examples might be duplicate therapy, so 2 medications doing the same thing, anti-inflammatories, which we are concerned about kidney function, blood pressure, bleeding risks. The benzodiazepines or other sleep medications increase the risk of cognition, cognitive decline, or falls. And I'm going to talk about the diphenhydramine and tricyclics here in a second. As we've discussed earlier, neurocognitive decline, there are risks in adults living with HIV. Acetylcholine is a neurotransmitter. It's a chemical in our brain that's vital for transmitting those signals for cognitive function. And then there's medications that can block that acetylcholine. They're called anticholinergics. Well, this is an example of one of those things where we are just more sensitive as we age. As we age, our body produces less acetylcholine. And so if you block that with a medication, as you age, you're blocking a higher percentage. And so you're more sensitive to the effects of that medication. And so when you have a high amount of anticholinergic agents, there's the increased risk for falls, fractures, delirium, and cognitive impairment. So we want to make sure that the medications aren't worsening or actually causing symptoms that we think are due to dementia or other medical conditions. We know that individuals that have a high anticholinergic burden, or they're taking a medication that's highly anticholinergic, or multiple medications with a little bit of anticholinergic, are 1.5 to 2 times more likely to have an emergency visit or go to the hospital. And again, examples might be antihistamines. So your diphenhydramine, which is in Tylenol PM, your sleep meds, a lot of the cold medications. Tricyclic antidepressants, which might not just be used to treat depression, they might be used to treat neuropathy or help with insomnia. Skeletal muscle relaxants, and one that I should have put on here is some of the medications for urinary incontinence and bladder disorders. Okay, so all of that makes it so important to have an ongoing, open conversation about deprescribing. A lot of times I talk to family members or friends, like, I went to the doctor, they didn't give me anything. And so it was like, prescribing is treating and doing. And I'd like to say that deprescribing is just a normal and should be part of the regular prescribing process. It really should be looked at as a patient-centered process where medications are reduced to improve outcomes. We're trying to reduce the risk of harm, such as those interactions, duplicates, side effects. There is a systematic process providers can use. There's a lot of tools out there, a lot of resources. And when those systematic processes are used by the healthcare team, reduce hospitalization admissions, reduce readmissions for complications. But it's really not a one-size-fits-all. It should be an ongoing conversation between patient, caregiver, prescriber. It's a two-way street where shared decision making. So maybe you gain information from your providers, you think about what matters most to me, what are my goals, what's my current function level, what do I want to achieve, and in that process you prioritize medications and decide which ones it may be reasonable to stop at this time. In terms of a survey that looked at older adults living with HIV, I'm not going to go through everything, but the high-level overview is most older adults felt, no, I'm not taking too many medications, my medications aren't a burden, and I don't want to stop meds. Not really. But if their prescriber or doctor said, I think you can stop one or more of your medications, would you like to try it? 80% said they would. And I think, A, that shows a high level of trust in the healthcare team and the healthcare prescribers they were working with. But I also think it kind of goes back to what Jeremy was saying earlier, is that people living with HIV should feel empowered. Those of us that are working in the healthcare team, it's our job to help empower individuals so that they feel comfortable to have open communication, to really bring up, these are the concerns that I have with my medications. These are the needs that I want to achieve. These are my goals, and are my medications actually helping me get there? I think as an individual living with HIV, being an active part of your medication management is vital. Keep a list of your medications. That includes over-the-counters, herbals, supplements. Make sure that all of your prescribers know what the other ones are prescribing, and when possible, if it's possible to streamline that so there are fewer prescribers managing your medications, I think that's wonderful. If you don't know what one of your medications is for, please ask. I do annual wellness visits, and I'll sometimes say, what is this one for? What are you benefiting it? And 9 times out of 10, it's, I don't know. And so really know that, because that's going to help you prioritize what you should be taking or what you might be able to let go. Making sure that you are surrounded, that socialization component, having your family and friends involved, support groups, learning from other people's experiences, I think is vital in optimizing the medications for you to make sure that they are helping you achieve what matters most. And with that, I will turn it over.
I think I'm going to hold this. I'm just too short, and they didn't provide me with a step stool. So, what can I say? It's kind of exciting to be here today. Back in the early 80s, I was asked to go to a conference up in Keystone when we were very first trying to struggle with the AIDS epidemic. So where we have come in the last 35, 40 years has been really, really exciting. So it's great to hear all of the advances that have been happening. What I'm going to do today is talk very briefly about a workbook called What Matters Most to Me, and that was specifically developed for the purpose of sort of end-of-life decisions. Not necessarily when you are on your deathbed, but as you go through the whole process of advanced care planning. You can use the 5 wishes, which we're not going to talk about today, but it does some of the same similar kinds of things, or you can look at this What Matters Most to Me workbook. Basically, what it's designed to do is to help people with serious illness get ready to talk with their healthcare team about what is important to you. What do you want to know? What kind of medical decisions are you willing to make? And how are you going to go about sharing those goals, preferences with your healthcare team, and then together deciding what is best for you? So, as has been mentioned multiple times this morning, a holistic approach is really what should hopefully matter to most people. So you want to look at your health, you want to look at you and your life, the kind of care you want, who the key people are in your life, and then, of course, your healthcare team. So one of the very first questions in this workbook is to basically look at what is your current health and what is your prognosis. What is happening to you and your health now? Is it stabilized? Is it progressively getting worse? Can you see, if you looked at yourself 5 years ago, that there's a significant difference? So that is one really big question. A second big question is, what do you want to know? Some people, and I see this all the time, say, just take care of it, or they want a loved one to make the decision for them. And on the opposite end of that spectrum is the person who says, I want to know absolutely everything about it, and I want to make my own decision, and I want to go forward with that. Either or somewhere in the middle is okay. It's just, again, being aware of what your own values are around it. The next one that we really want to look at is reflecting on you. And as you look at yourself, try to describe, what does a good day look like? Is it a day when you can go out and exercise? Is it a day when you have lots of interaction with friends and family? Is it a day when you're pain-free? And then take a look at, what is a hard day? Is a hard day one when it's very hard for you to get up out of bed because mentally you just can't manage it? Is it a day when you are in chronic pain and you find yourself reaching for that narcotic just to be able to move? And then a third piece of this is, what are your goals for the future? What do you want to do? Many times in my work, I hear people say, I'm going to live until my daughter delivers that baby, or I'm going to make it through Christmas. Or a person who, maybe those of you who have been involved with the Health Sciences Center and the geriatrics program over at the medical school, a guy by the name of Dennis Janigan, who was a bright, shining young geriatrician, developed brain cancer. And his big goal was to do the Pikes Peak walk, and he did it, and about 2 weeks later passed away. But again, it's, what is it that you want to do? What kind of care do you want, and what kind of care do you not want? So again, as we've heard earlier this morning, there's a lot of different kinds of care that is available, and some of it you want to take advantage of. What is your prognosis for the future? What are the specific details? So are you one of those people who's going to get up every day and exercise because you know that that's going to add a certain number of years to your life? Again, the really big question is, what is your involvement in not only your health care, but also your decisions around that? One of the things that I have seen many times in my work is that people want the magic pill. It was just stated. My husband falls in that category sometimes, and I have to tell him, no, get out of the chair and let's walk up to the park. That's just as good as another med. Another thing that we struggle with in sort of aging is, do you want to be at home or do you want to be in a facility when your condition changes? And I'm going to say that 99% of you in this room are going to want to be in your own home. So what is it that you are doing to make sure that that happens? What kind of planning are you doing? If you're interested in some of that, I have done a number of sessions which are posted on our YouTube channel at the Colorado Gerontological Society. And it talks about things that you can think about in terms of making your home ready as you age to stay at home. And another big thing is, who do you want to know about your condition? Do you want people to share, or do you want it to be very private? Other preferences are talking to your healthcare team about your own philosophy, your own values, and what is practical. It may not be practical for you to stay in your own home if you've had a severe stroke and you cannot move the whole left-hand side of your body and you don't have a caregiver who is trained or physically able to do that. What do you worry about? Do you worry about being sick? Do you worry about dying? Do you worry about leaving enough money for your family to take care of you? What is your biggest strength when you are in a difficult time? So do you pray? Are you one of those people who get up and move around? Do you clean your house? So what do you do to basically keep yourself going? What activities do you enjoy, and how does that bring meaning to your life? And what do you hope will happen in the future and not? Another thing is, who is on your healthcare team? Obviously, your primary care provider, whether that's your physician, your nurse practitioner, or your physician assistant. If there's a social worker and or a therapist, whatever medical specialists you have, whether they're neurologists, geriatricians, podiatrists, whatever. And then one of the things that we have found is, what are the community agencies that you rely on? So for example, our agency spends a lot of time working and helping people with public benefits. So we have a group of people who call us every year, and I'm sure that's going to increase with the new Medicaid requirements. As their form comes that says it's time to sign up again for your Medicaid, they simply get on the phone and call our office and say, can you help? Do you rely on clergy? And then who is your medical and financial power of attorney? And I just want to emphasize that if you have not made that decision, please do so. And I'm not asking you to do it when you get older. I'm asking you to do it at age 18. And the reason for that being, because we never know when tomorrow something might happen. So, are you now ready to talk to your healthcare team? So if you want to complete the workbook, you can do it either alone or you can do it with somebody. Take your time. It doesn't all have to be done today. You can do it in bits and pieces. You can reflect on it. You can say, I'm going to do it today, and then not go back to it for another month or two. Nothing wrong with that. And then share what you have put down. Don't keep it a secret, because if you keep it a secret, as I often tell people, when I become their power of attorney, and over my many years of work, I have done this for many, many people. If you don't tell me, and if I don't understand what you want, I can't share that. And one of the things that's really important in your medical power of attorney and your financial is making sure that those people understand what you want, not what they want, okay? And then lastly, the book really does help you articulate and be more clear about what you have or find as interesting. So the book was created actually in partnership with the Conversation Project, which is up in Boulder, and then with Adrene Labs and the Institute for Healthcare Improvement. There's the link for it on your website. And if you just Google what matters most to me, the book will come up and you can download it. And it's available in English, Spanish, and Chinese. For whatever reason, whoever was involved with that project had that as a major goal, and so they did it. Thank you all, and I'll talk to you soon.
All right. Oh. Important. Thank you so much to our speakers. And now on to a panel discussion. We can invite our speakers up to the front and open questions from the audience. Michael, you're first in line, for sure. Here, let me.
Eileen, right? You have an event coming up, the Colorado Gynecological Society. You didn't say anything about it. Do you have flyers out there or something? It looks really good. That thing that's coming up. Okay. So, question, I don't know if this is for Jacob or Christine, but I think the two of you can do it. We don't hear much about it anymore, but if I'm correct, the HIV virus is the only thing that crosses the blood-brain barrier, correct? And the blood-brain barrier is pretty amazing because we evolved that way to protect our brain so bacteria can't get through. And I don't think hepatitis or most viruses can, but HIV
herpes
can.
would, because we get herpes encephalitis. And herpes.
Louder?
Herpes should,
Okay.
I believe, crosses the blood-brain barrier.
And am I correct that efavirenz is the only
Syphilis.
HIV drug that crosses the brain barrier, or there's newer ones that do? Because we don't hear about it much anymore.
So
There's like a pharmacologic index on how well the drugs cross the blood-brain barrier. I think there's a lot of debate on that. Maraviroc was supposed to, which is why they did that neurologic study on Maraviroc.
That's right.
But yeah, we don't hear as much about it anymore.
The only reason I'm asking is that this question about why, and not that there's anything we can do about it, because once the damage is done, it's done, but why people with HIV are at a higher risk, why we have higher risk for dementia, higher risk for Alzheimer's and all of that. I think it's, the virus gets up in there and it does damage and it's never coming back, is it? You're never going to get better from
we've never found a way to reverse it. Controlling HIV is the best way to control HIV-associated neurocognitive disorders. It's not the only virus that can cause cognitive impairment. Like Christine said, there are a few others. We've also never yet proven that medicines that cross that blood-brain barrier are any better at controlling hand. So there's no right medicine no right HIV medicine for treating hand that we know of.
But you would admit that the risk factor is higher for people with HIV because of the virus in the brain. It has to be, right?
Yeah.
To a certain extent.
Multiple other factors as well.
Multiple, yeah, exactly. Thank you very much.
Here?
To Dr. Abrams. Did I read that statistic correctly about pollution? Was that 70%?
About what? Sorry, say that one more time.
How it affects you in HIV? It had pollution at the very last bottom.
Ah, now I know exactly what you're talking about. Yes, actually, I should probably pass this over. But exactly, air pollution is one of the factors that it's in the latest Lancet report. I don't know if it's been in prior ones.
Have they done any studies about microplastics? Because they're in everything.
There are a lot of studies linking air pollution, microplastics, water pollution to risk of cognitive impairment long term, and it's identified as one of the things we can modify the most. Like, we can do something about pollution. So it gets highlighted as something to fix, although a lot of the associations are a little tough to pin down and really quantify.
I have a two-part question. My first question is that most of you all, is your work location at Anschutz campus? Yes, four? Yeah, because I go to Denver General, and after hearing what you're saying, I'm thinking about changing. Well, I mean, not that I'm getting not that I'm getting bad treatment, but I think I would get better treatment. That's what I'm saying. My second question is for Dr. Is it Ricchetti? Ricchetti. I grew up with Italian Americans, yes. Talking about the different drug interactions. If I came to see you, would you be able to give me feedback on all the different drugs that I take and how it would affect me?
Can everyone hear me? Yes. Okay. So yes, so that is part of my role in my clinic is to meet with individuals, go through their full medication list, identify which ones are contributing to achieving goals, which ones might be interacting with one another, which ones may be causing side effects, and I usually wrap that up with a bow and send it to the prescribing provider. Now, there are some pharmacists and community pharmacies that are also available to make some of those appointments. I have high respect for Denver Health, Denver General, and I know there are pharmacists embedded in some of those clinics as well to see if they're available to do a full med review with you.
Okay.
Can I also do a plug for Michael? One of the things that I was seeing is that there's some early reports of getting shingles vaccine to prevent shingles because that also lies dormant in the brain and reducing risk of dementia later in life. So sometimes vaccines and things like that can be preventative as well.
Oh, so you're saying the shingles vaccine helps to prevent dementia?
Potentially, we're seeing some
Really?
early positive results.
My grandmother had dementia. No, my mother had dementia. My grandmother had Alzheimer's. So, okay, it's time for me to get the vaccine. One.
The Liverpool. Oh, go ahead. HIVdruginteraction.org. It's through Liverpool.
The University of Liverpool is probably the most well known.
Do you accept Medicaid?
Not Denver Health Medicaid at the university. Depends on the Medicaid.
Okay. Thanks. I'm a retired primary care physician, and I see University of Colorado School of Medicine. You're all talking about teams. You're all talking about teams, and I agree with that. But I am appalled by the increasing compartmentalization of healthcare. And therefore, I think that each one of us here, and I'm finding myself now moved from a position of a healthcare provider to a patient, a client. And I think that all of us need to buck up and become our team leaders. And I have found that during the many times that I've been hospitalized over the past 10 years, I have been in the hospital bed telling doctors, and I've got like 6, 7 doctors coming and visiting me. I'm saying, it's not your turn, sit down. It's not your turn, sit down. I want to talk to this doctor, then I'll talk to you. And I think that all of us, I mean, I can do this because, I've got credentials and I'm a white male and all that sort of stuff. But I think all of us need to take responsibility and consider ourselves to be the champion of ourselves.
I've got a question for you. I'm on 9 pills and injectable drugs. Is that considered polymorphin or polypharmacy, as you called it before?
9 pills and injection drugs?
9 over-the-counter drug or prescribed medications, and then injectables for HIV control. Cabenuva.
So, I mean, you are probably a classic example of polypharmacy, and I think it's very reasonable on a regular basis to have that discussion. Is every single one of these medications needed? What benefit is it providing to me? And as long as the answer is yes, they're needed, yes, I'm still getting benefit, that's maybe the end of the conversation. But if it's like, gosh, I started this medication and now I feel dizzy more, or I feel this more, or having to take this one 2 hours away from a meal and this one 4 hours away from a meal, and now I'm struggling, that's when you have the conversation, is what can be changed to make this easier for me?
One more question. This is something I've noticed that when we get, say, a hospital visit, I was in a hospital for a heart attack back in May. They prescribe new medications, but then it takes me forever to get them all synced up because I'm trying to save whoever's paying to send them to me, get them all sent to me at one time. And I think that's important as well because, you know, why should I have to every 2 weeks go on my chart and say I need to order this medication and order this medication 2 weeks later, get everything synced up. And I think that's something that needs to be done, you know, between Denver Health and UCH Pound, which, you know, people are going to.
Can I respond to that? That has nothing to do with the prescribers. That has to do with your Medicare Part D, and when they fill, well, it has to, Medicaid as well. It has to do with their fill schedules and when they'll allow it. And I personally have never been successful in going in and trying to get those synced. So if there's anybody else in this room who's done that, I would love to know what your secret is.
I do it by short fills. I request them to do a short fill and then do the full fill later on. What I do it is I get them to do a short fill and then I go for a full cycle.
All right, we have time for one more question.
Hi. I just want to comment on what I didn't hear today, and that was external environmental factors that affect the health and wellness, the socialization of older adults. So just for one question, did anybody come here today by public transportation? One person? Okay. Meant we had to drive to get here or take an Uber. But I made a mistake coming here. Oh, bicycle. That's great. Yeah. Winter is a problem. For me, I don't want to fall, so I don't go out in the winter. So I don't get as much exercise, and I don't go out. I don't want to go out after dark anymore. And I am still not at a feeble stage. We see lots of people who, with the means, go live someplace else in the winter. I just wonder if that is something to be considered around mobility, weather, other environmental factors, the fact the city and county of Denver is making it more difficult to drive, which has a higher impact on older adults, and the lack of parking. When I was working in an organization, the first question is, how much parking is there and how close is it to the event that you're having? I wonder if that's something that any of you have considered as part of this, the 5 M's, because I don't see the environmental stuff.
Yeah, sometimes it's kind of hard to like squish an issue affecting older adults into one of the M's, but we try to find a way. I think the built environment really affects mobility a lot. But your comment is a really good example of how there are infinite facets of ways that you all can help try to improve the lives of all of us as we age, whether that's the built environment, public transit, Medicare policy, polypharmacy. Like it does go beyond the 5 M's, might not fit perfectly into that framework. A great example of that is that we did a basically aging review of the built environment at the Anschutz Medical Campus and found a horrible environment to get around. Like doors that you couldn't open from one side and like clinics that you couldn't get to in a wheelchair. It was a mess. So they're making improvements, which is great. But that itself was another good example of how attention to the needs of older adults in the built environment, in policy, can help everyone, regardless of age, regardless of ability status. So if you have your own niche in the world, it can be leveraged to help all of us age better.
I think that's a great answer. And also a wonderful question to keep in mind for our next session following our break, where we're going to be discussing how we've taken many of those considerations in mind in developing a lot of our healthy aging programs at Colorado Health Network. But then also as a community and across sectors, specifically HIV and aging sectors, how we can work together to expand those opportunities. But Lupe, I don't want to say no. But I think everyone wants a break. So thank you so much to our amazing speakers. know how to turn it up. Hello? Oh, got it. Yeah. All right, everyone. We are going to reconvene. I know there are probably some people who will be filtering in. I just want to take a moment to highlight some of the activity that's happening at the front. This is Karina Branson. She is a graphic note taker and is essentially illustrating all of the discussion that is happening today. So definitely want to give a big shout out. I feel like every time I'm looking over, it's just developing more and more. All of these images will be digitized and then shared out to everyone in attendance as a deliverable, and just a really fantastic takeaway of what we've discussed as a forum, but also kind of the culmination of everything in terms of how we can support our community of older adults aging with HIV. So definitely like amazing work. Take pictures, post on social media. It's really exciting to have you here today. Thank you so much. Yeah. All right. Well, so we've already had introductions. I'm Erin Burke-Lever, she, hers. I'm the Director of Community Engagement at Colorado Health Network and also the PI for our HRSA SPINS HIV Aging Initiative, which we'll be talking about in more depth. And Haley Sanner.
She, hers, and I'm the Healthy Aging Programs Manager at CHN.
And co-PI of our HRSA SPINS HIV Aging Initiative. And so for this next session, we felt that it was a great opportunity to really highlight our HRSA SPINS project, but also kind of give a layout of how we actually came to developing our healthy aging programs at Colorado Health Network. So very briefly, some business, needing to acknowledge that this is a HRSA-funded project through the U.S. Department of Health and Human Services as part of an award, the HRSA SPINS HIV Aging Initiative. And that, as a quick note, the contents of today and of what we're about to present are ours and don't necessarily reflect the views of HRSA, HHS, or the United States government. Yay! Never know if that's gonna work. Thank you. Thank you very much. So before we dive into iChange, we really want to take a moment to acknowledge the bigger initiative that really made this project possible. So our SPINS HIV Aging Initiative, formerly titled Emerging Interventions to Improve Health Outcomes of People Aging with HIV, focuses on people 50 and older living with HIV. And the goal was to essentially identify and test emerging strategies to address not just comorbidities, but also geriatric syndromes, behavioral health, and other psychosocial needs of our community. Of older adults living with HIV. So the initiative really challenged us in three ways. So first, to develop and implement a new intervention, test it, and integrate it into our existing HIV service frameworks, and then also to evaluate the overall impact of these initiatives on our community that we're serving aging with HIV. So not a very easy lift, especially in a 3-year period and a 1-year intervention period. So today a good portion of our time will be focused on the SPIN supported project, iChange, which stands for Integrated Care for Healthy Aging and Navigation of Geriatric Effects. So here's a look at our national cohort of demonstration sites that were also funded through the SPINS initiative. So as you can see, we are in very impressive company. Dr. Jacob Walker, who presented in our first session, serves as the PI at University of Chicago, but also practices here at University of Colorado Anschutz, as well as Yale, Mount Sinai, among many others. So a lot of really like powerhouse institutions, many with very robust academic medical centers, as well as long-standing geriatric HIV research programs. And then, assuming this works, nope, well, you can see the blue square. There's us, Colorado, but specifically Colorado Health Network, and affectionately known within our cohort of demonstration sites, the little ASO off of Colfax. So we're definitely one of the smallest sites. We're one of 2 community-based organizations that were funded through this initiative over the past 3 years. However, we did not let this define us, and in the end, we feel that doing Colorado proud, we have moved mountains in this space of HIV and aging care. So not only did we develop and implement a unique and emerging intervention and strategy for models of HIV and aging care, we also became true collaborators across this national cohort, really working alongside these institutions. We've shared what community-based care can look like beyond the academic and clinical settings. And so this blend of grassroots insights was really a cornerstone of our iChange project, and we're very proud of where we've come today. So many of you may be familiar with Colorado Health Network. Maybe show of hands quickly. You might be staff, client, provider, partner. Okay, that's great. Excellent. So Colorado Health Network, for those who aren't familiar, is a statewide AIDS service organization. We were established in 1983 and have been serving communities living with or vulnerable to HIV for more than 42 years. As an organization, we serve more than 5,600 clients living with HIV across the state and provide everything from medical case management, housing support, dental care, emergency financial assistance, prescription drug coverage, and ADAP, Helen in the front. But what really matters for today is that over half of our clients we're serving are 50 and older, which really means that aging isn't just a footnote, it is front and center. So how did we get here? So like you, we started noticing gaps. We recognized that we had a growing population of people aging with HIV, and we wanted to know, like, well, what can we do to assist them and provide better care? Recognizing that many of our clients who were aging with HIV, are aging with HIV, are navigating a lot of complex issues and challenges beyond just their care, but also stigma, isolation, complex health needs, and also just a system of HIV services that wasn't really built with them and their aging well-being in mind. So, I imagine many of you are familiar with the Ryan White HIV Care Continuum. Just wanting to take a second to acknowledge first, before we get into some of the details of this particular slide, that older people living with HIV are doing a really incredible job of staying in care and also achieving viral suppression, which in this particular slide you can see in a 2022 Ryan White program client level support, 93% of people 50 and older served were virally suppressed, which is pretty impressive. But we're not done. And it's important to note that the HIV care continuum really only tells part of the story, and that the real continuum for older adults is longer, much more complicated, and frankly, more human. So our team at Healthy Aging Programs at CHN incorporated this 6th step within the care continuum, which is really highlighting, how do we age successfully across the care continuum in achieving viral suppression and aging well with HIV. So this really recognized a need to bridge services across both the HIV and aging sectors, and a significant paradigm shift in how we approach these care delivery models. So kind of a last minute highlight is that the Older Americans Act actually updated the 2020 guidance and language that recognizes the need of LGBTQ older adults and those living with HIV. That update was more symbolic and really opened a door to providing more inclusive aging care and services to these communities. We have materials on that particular guidance at our Healthy Aging table, so certainly we'll encourage you to stop by. And again, this shift really creates a space to bridge these sectors and invite geriatric principles into our HIV care. So with all of that said, this paradigm shift really allowed us to ask, what would it actually take to support people aging with HIV to thrive and to age well? So the question really has led us here today in the creation and the establishment of our Healthy Aging Programs at CHN. And we started really in 2019 with a number of community forums with our community of older adults to ask what they need. It also was an opportunity to collaborate with Dr. Christine Erlandson in the development of various pilot programming, which eventually led to the creation of our first initiative, our Path to Wellness program, or People Aging and Thriving with HIV, which was formally established in 2020, conception in 2019. And the idea was very simple. If physical activity improves clinical outcomes, how can we translate this into a community setting? So we did, and established Path. We actually completed a publication that came out earlier this year that really highlights the outcomes of that initiative, which began as a very small cohort study, but has since expanded in the last 5.5 years. The program, Haley will actually be going into more detail in the next few slides, was an opportunity to also acknowledge a lot of the gaps in this particular initiative that highlighted that many of our clients who are interested in participating couldn't, and much of that had to do with competing priorities, which some of those challenges were already addressed in the Q&A during our panel session around, trying to get transportation, trying to address housing needs, trying to address mobility issues, trying to address making clinical appointments. So it was an opportunity to explore how can we establish more geriatric focused care within our HIV care setting. This essentially, and again, Haley will go into more detail, led to the development of our iChange initiative. something that allowed us to be able to intentionally and thoroughly not just screen for various geriatric conditions, but also identify various needs specific to and individualized to our clients. And with that, I'm going to pass it over to Haley. And yeah.
Thank you. So I'm going to go in a little bit more detail about our different programs. As Erin mentioned, our Path to Wellness program has grown in the last 5 years in collaboration with our team, with collaborators here, with our community, and stays rooted in 3 pillars of movement, connection, and nutritional health, but has grown to not only be a weekly group-based offering, but also have smaller cohort-based offerings that allow people to explore different things. We have more information at our tables, but I'll give a little bit of an overview so folks understand what's going on. For movement, we offer weekly pedometer step-based goals, so folks can get a Fitbit or another type of pedometer to encourage them to continue movement. As we said, exercise works. So continuing to do that and have an accountability and a resource to be able to improve that. Also in our group on Thursday in Denver and on Fridays in Colorado Springs, we'll do low-barrier physical activities together as well. For connection, that's our Thursday and Friday groups are really core to that. So happening weekly and involving the community in what we want to see and what we want to do together. We have community resources come and speak. I know people in this room who have come to speak and presented. We have group members present. We do different creative activities. We do things based on nutrition and physical health. So really all over the board. And if you're interested and have an idea that you would like to present or share in our PATH group, please reach out. We'd love to connect. In terms of nutrition, again, in the group, we'll share different resources and do different activities related to that as well. And as I've mentioned, these have grown based on folks' interest and needs that have arisen in the group into some smaller cohort-based programming as well. So in our regional office in Colorado Springs, we do some digital connection work in collaboration with Senior Planet and have different trainings focused on that. We have collaborated with our behavioral health team and with peer leaders to create Aging Positively, a part 1 and a part 2, which is a psychosocial group exploring positive aging. A lot of the stuff that Phil spoke to in the beginning of this session, that internalized ageism, internalized stigma, and how we can work through that and share our stories. We've also are collaborating with one of our past teamers and Dr. Erlinson to create a falls prevention program specifically in-house for folks. So lots of things going on and lots of things that folks can get connected to after they go through iChange or before. So the majority of this I'm going to spend talking about the nitty-gritties of iChange. So iChange is based on the geriatric 5M framework that we learned about this morning, and why we really wanted to give you all a context to lead into our discussion today, to kind of see that at a high level, see it in clinical practice and in geriatric work, and how that can come in to the work that a community-based organization can do to support folks aging with HIV, and continue to assess folks' evolving needs and really focus on quality of life. So iChange has been developed by our internal team alongside our patient liaison, Robert, who's going to talk a little bit more about his experience after me in the next session, as well as our collaborators, Dr. Abraham and Dr. Erlinson, as well as having got a lot of feedback from community and folks who have gone through the process as well to continue to improve it. So the 2 main parts that I want you to kind of remember as we go through this process is the first part, our iChange screener. So this uses a lot of different evidence-based screening tools to look at the geriatric 5Ms and really take a holistic approach at someone's needs and someone's context and what's important to them. These are all designed for a non-clinician to be utilizing. So they're not diagnosing certain things, but they are really identifying potential areas of improvement, potential risks, potential vulnerabilities, potential strengths, and how we can incorporate those things together. Then the second part is we take that screening and with a client, we have a personalized care plan development. So we share these different screening tools and the different things that came out of our first discussion and create goals that align with that and really align with what matters most for an individual. So the core goals of this is to screen, bringing that comprehensive geriatric screening approach within an HIV sector community-based organization. Then empower folks to use these different screening things or the things that came out, and maybe risk detections or strengths to advocate for themselves and advocate for the way that they want to age. And then connect folks to further resources or other specialized services within the aging or HIV sectors. Many of you have been referrals, both indirectly and indirectly, for your different programs, and why we're excited to have everyone in this room together and really see that connection across the board. So a little bit more in detail. First in the process, as we went about developing this, we had to train our team in the different geriatric approaches. So a lot of what you learned this morning, we've had kind of in-depth training on all of those things to really be able to incorporate that and make sure that this process embodies all of those things. We are able to train folks in that caveat. If you're interested, you can let us know. But again, you'll see these two parts. So that first part is typically about an hour to 2 hours, kind of depends on the individual. Some people have a lot to share and may kind of need time to go into a lot of these different processes and a lot of these different screenings, which I'll talk about in a second. And these screenings are not just questionnaires, they're action-based, and they're also listening and conversational, because we know a lot of things happen in that in-between, so that as a provider, kind of making sure that we're picking up on those things as well. Then when we go into part 2, we do care plan development. So again, we show everybody the things that we looked at in the screening and the things that we heard the individual say, and we come up with milestones together. And then whatever would be supportive for them, we create a kind of tracking of those milestones. How can we help you be accountable to those things? How can we support you in maybe reaching out to referrals or supporting your goals? We had folks go through a follow-up procedure. We did this based on folks' MOCA scores, so their cognition screening scores, where folks either came in at 3 months, 6 months, or 12 months to kind of reevaluate these screenings and kind of see what has changed, as well as go through the screenings again and talk about the goals and milestones and maybe reevaluate them, maybe continue them, maybe come up with new ones. So when we talk about the geriatric 5Ms, here's the different ways that we brought these into our screening approach. So multi-complexity, a lot of these things come up in a wellness exam, an SER, for those in the HIV sector. But wanted to make sure that we were incorporating all these things to see if anything were changing or things that we should note while we're looking for referrals or things that might be important to help someone succeed in their milestones. For example, if someone isn't housing stable, maybe we need to address that first so that we can then support them in the quality of life and the other goals that they want to achieve. And as Dr. Abraham talked about, right, multi-complexity goes through everything. And a lot of these 5Ms are overlapping, so you'll notice that throughout these screenings that there's elements of each of them that kind of piece into the others. And that's why that conversational element throughout this process is so important. So for mobility, the different things that we use to measure our physical function included Zibrio, which is a balance scale, looks like a physical scale, and folks stand on it for 60 seconds and gives an objective measure of balance and is predictive of fall risk. There's some questionnaires related to that as well to highlight folks' fall risk as well. We also use an app-based program called Hear Who and Who Eyes by the World Health Organization to screen for vision and hearing. Again, none of these are diagnostic, but allow someone to kind of bring awareness to sensory loss and sensory needs so that they can connect with a provider and a specialist down the road or after this process. Then we talked at the Lawton's Instrumental activities of daily living. So really recognizing kind of what someone's daily life looks like and what are the different things that are important to them, or maybe areas that could use support to allow them to continue to age in the way that they want and the way that they are. Next, so medication. Again, we are not clinicians, so unlike Dr. Ricchetti, we can't necessarily go into the in-depth polypharmacy that she can, but we can highlight some of the questionnaires that she talked about medications, and have folks bring those medications to the table so that then they can have them when they want to go to a provider and have these listed out and support them in that conversation about polypharmacy with a provider. We know those conversations with providers can be really short, 15 minutes at times. So when we can spend more time together to plan this out, we can help someone maximize those 15 minutes with the things that are important to them. We also use the HIV treatment adherence visual analog scale to bring up adherence to HIV medications. So mentation, this is a really big one for us. We do the MoCA, the Montreal Cognitive Assessment, which again is not, doesn't diagnose dementia, but brings up folks' potential cognitive impairment and brings that conversation to the table and allows people to be aware of where they are in this moment. And again, it can be something that can be used when talking to a provider for any further screening, or if there's any kind of risks that are coming out. Then we use the patient health questionnaire to go into things like depression. And we also look at social isolation and loneliness, both that subjective feeling, the feelings of loneliness, as well as the objective feelings of how many people are you around, who do you interact with. And a lot of this also happens in conversation. So recognizing like what people's quality of life is and what people want out of their social interactions, and how we can create goals to support that, and as well as connect people to our different programs that may help people do that. And then matters most. So Eileen talked a lot about this. We brought into the conversation advanced care planning and kind of introductory topics and questions around that to inspire folks, if they haven't taken these steps, to dig a little deeper and maybe create a goal around advanced care planning and build that into something that hasn't really existed within the HIV sector more recently. We brought up some questions about elder abuse as well, knowing that there's a lot of scams and frauds out in the world, so to bring awareness to that conversation. But again, this matters most is really flooding through everything. It's something that we're looking at the entire process, and something that we are centering throughout everything we're doing in iChange. And you'll really notice that when we go into the care planning. So when people come back a week later, we bring to the table all these different things that we looked at, and we take a lot of notes about what we heard from folks, so that we can have this conversation about, here's what you said that may be your priorities. Does this feel accurate? Let's go through these outcomes together, and let's pick those priorities. What matters most to you? And make sure that an individual is telling us what matters most to them, and we're not just dictating that as the provider, really empowering someone to challenge us and say something different that may not have come out in the original conversation as well. So we co-create those milestones, try to write them in a way that is measurable and allows people to maybe are realistic and timely and all these different things, but what kind of activities would help support people in achieving those goals. So we list those out, and we print everybody this action plan where they have all the different results, they have all these different notes that they may want to take to a provider, they have their milestones. We have some folks who put that up on their fridge, some folks that keep them with all their medical things, some folks that maybe put them somewhere else. But people that really have succeeded in this are folks that really looked at those goals and tried to keep track of what they were doing and kind of go off this action plan. And then, depending on an individual, we talk about how would you like to be accountable to these goals. Does that mean text calls? Does that mean occasional emails or an update when we see you, or schedule a meeting a couple months from now to re-talk about those? That's really individualized. Some people are very on top of the things that they want to do and feel very comfortable with that, and others would like a little more support, and all of those work. So this is a hypothetical example of what this could look like. So you'll see on one side, you'll see the different screeners, some different categories that we've included. If they had a measurement, they'd be listed there. On an actual care plan, it would also tell you where that measurement lies in terms of your risk, or what that categorizes for you. And then if they come back for a second screening, you'll see they'll also have their scores related to that screening as well. So they can see if there's any changes. Maybe someone's fall risk went down, went up, and their balance was a little bit lower because they had a hip injury. And so, okay, that makes a lot of sense that happened. Or maybe they've been really focusing on, reading or getting more social, and they've noticed that their cognition score has gone up, and so that's something to celebrate. And as you can see, we've, put in some different milestones that were important for an individual. Some of these things were something that the individual was going to do themselves kind of individually, like reading and kind of creating a tracking device for that. Some were attending different external referral groups or groups within our programs, and others were connections to medical and clinical specialists, which could be helping them get set up with the appointment, or could be, again, getting a list of all these different things that they want to bring up to a provider. So this is just a chart that kind of shows of all the different participants that were involved in our program. And I think the count was 48 who went through the entire program and went through the different reassessment stages as well. Here are some different referrals, both direct, meaning maybe we had to send in a referral, versus indirect, where we gave someone, here's the different social groups that you were wanting to go to, but maybe didn't have an actual referral form that were included in people's goals. So you'll see there's a wide variety of topics across the different 5 M's that really support folks in what aging looks like to them. I think something that we heard a lot was that this really brought up conversations that maybe hadn't happened before with providers or within community-based organizations, and brought new things to the table and new awareness to things that were important to them. So as you'll probably notice, we really love the socio-ecological model. So just kind of looking at this from the lessons that we've learned. From an individual side, we heard from folks that this felt pretty empowering, and that process of identifying and prioritizing what matters most to someone was really important. And again, something that wasn't always asked, as Eileen brought up. A lot of folks haven't really thought about some of those questions about what's important to you, not only as you maybe are preparing for advanced care, but also just how you're living your life. So we really want to advocate for that, and also promote self-advocacy for folks to be able to manage their health confidently. Then interpersonally, as folks in our group can probably attest, since we started doing this, we had a lot of new members join PATH and other programs we were doing, because it really brought a lot of awareness to folks who maybe hadn't heard about our programs or hadn't been interested in our programs before, but for whatever reason, going through this process really highlighted goals or things that they wanted to focus on that PATH could address or PATH could collaborate with. We also noticed that when we went through this process, we knew a lot about our clients in ways, and we knew a lot of their interests. So we were able to tailor kind of different sessions that we were doing in PATH to interests that we were hearing in iChange. We had folks bring to the table an opportunity for sharing milestones within PATH to really help talk about accountability and talk about goal setting within the group setting, so it can kind of balance out with some of that individual work that was happening in iChange. And then organizationally, we were able to adopt some cross-departmental approaches to specialize aging roles within different teams, and create some new internal referrals and external partnerships to really bridge that gap between HIV and aging. So one of the ways we did that was we piloted a geriatric medical case manager role. And so kind of the 3 big steps that we used to get here, where one was recognizing, looking at the standards of care within Ryan White that kind of outlines everything for medical case management, that we can have age-specific roles supported by these funds. Older adults living with HIV are already in care, so just having a kind of centralized person focusing on older adults in case management was really supportive. We then worked to develop a procedure to shift caseloads such that age-specialized roles have caseloads of entirely clients over the age of 50, while also being representative of average organizational caseloads. And then some of that specialized training that we created as we created this whole model, we used to introduce people to the iChange screening process and procedures, as well as introduce folks to all these different pillars of HIV and aging that we talked about this morning more in depth, so people could feel confident and comfortable to work with folks as they navigate aging with HIV. That's most of it. I know there's probably a lot more, like many people said, that we could talk about all day, but did want to open the floor to questions for Aaron and I, if anybody has anything or comments from the crowd.
So this question for Aaron. I was unaware of it and was pretty impressed with the different sites that are doing this thing. Especially some of them are really huge things compared to our little building on East Colfax, I guess, if you want to look at it that way. But especially the one in Puerto Rico, I mean, that's a major thing, and Case West or whatever. Anyway, so of that $1,050,000 grant that's divided amongst how many up there?
No, that's for our grant over a 3-year period.
I thought that was divided between them all. No, but is that the amount that every site gets, or does it depend on their caseloads and their?
If it was requested, it was no more than about $300,000 per year for a 3-year period could be requested, and then there's also like in kind and.
So the CHIN program got $1,050,000 for 3 years of doing this. Okay, and where are we at in those 3 years, and will it continue?
We're in our last year.
Will it continue?
Yes, it will.
Thank you.
Yes, that's this initiative, I guess, to provide a little more background. We are in year 3 of a 3-year funded project. This is our dissemination year, so essentially looking to disseminate all of our efforts to the broader community, but also looking at how we can collaborate to continue and sustain our work, not just within CHN, but also across other ASOs. And again, we were very particular about wanting to collaborate with other community-based organizations serving the same community that we're serving to really help integrate and provide technical assistance for. Yes, it's from HRSA, the HRSA Part F, Special Projects of National Significance. Allie.
Thanks. Great presentation. So I had 2 points. One was from an earlier comment just about being engaged in your own care, being the leader of your care team. You know, patient activation is such an important component of better outcomes. So I just wonder if you could comment a little bit of sort of how you facilitated patient activation, patient engagement, being the leader in your teams. And the other comment just came from some conversations about just the loss of care we're seeing in sort of rural areas. You know, so how do we sort of make sure that we translate this to a community program that really provides access in rural areas, given sort of the dearth and the loss of care providers?
Well, so we'll tag team. I think in terms of like activating and empowering clients was really in the transparency around our screening initiative, that part 1 of iChange. But then again, the transparency is in that part 2, care planning and engagement of the client in their health and milestones and various like steps they can take to address their health in the various domains that we assessed. But also, I think something that will be highlighted in the later sessions is also working with our patient liaison, Robert, who really helped in developing how we work with our clients in managing, how we're administering iChange, how we're navigating the process with clients, and who also was fundamental in collaborating with clients as they also went through the process. But I'll let Haley elaborate too.
Yeah, I think something that we noticed when we talked a lot to our other demonstration sites who were coming from a more clinical angle was them asking like, oh, like, are you having a doctor involved in these things? And one of the steps that we brought up a lot is, again, listing out, these are the things you told me you wanted to talk to your provider about. Let's make a goal around that so that you can self-advocate for yourself, because I am not a clinician, but how can we kind of build that bridge together and make sure that what's happening here is supportive of what's happening there and how we can collaborate, and that when we talk to our other demonstration sites, a lot of them were doing similar screenings and things, but other people weren't sharing some of these results with folks. So that transparency part was pretty unique to the things that we were doing. In terms of rural, one thing that we have designed this to be done virtually over Zoom or over the phone. A little bit easier over Zoom than it is over the phone, to be able to start doing this outside of a more urban area, or if there's other kind of transportation barriers or things going on.
Yeah, and also want to highlight one of our initiatives that, developed through some award funding we received, or prize funding, was a tablet hotspot lending program, which specifically focuses on our older clients living in rural areas. And all of these screens can be administered virtually. But also recognizing that not everyone has access to that hardware or tablets or, stable internet connection. This opportunity was very helpful in being able to enable us to provide that service so that they could feel more connected and still engage in our programming. So it's still in the works. We have a lot to do, but yeah, it's a start.
Well, we don't want to be the people standing between you and lunch. So again, take a moment if you want to look at the beautiful artwork that Karina has been making about our conversations today. And hopefully you can meet some new people over lunch. And if you liked anything that you saw today and want a little bit more information, reach out to us, or you can look in your folders and there's handouts about all of our different programs that could be helpful for you or others. And then we're really excited to come back after lunch to hear from Robert and a panel of clients to share their experience of the iChange process and involvement in our programs. So thank you.
Good afternoon, everyone. Good afternoon, everyone. MJ. MJ, Calvin. Calvin, that crystallized walking stick really stimulates some conversation. All right, everyone, thank you so much. We hope you all enjoyed your lunch and conversation and our fabulous mentors, or vendors and mentors. Sorry, I'm thinking of Robert. Robert really doesn't need any introduction because Robert is such a phenomenal presence in our community broadly. Yes. Not only is he a colleague, a collaborator, an advocate, he's a friend and a mentor, and we have, we're so grateful that you're here today to present. So I will actually read Robert's bio. Robert Reister, a Denver native living with HIV for over 40 years, is a client services manager at Colorado Health Network and patient liaison for the HRSA HIV Aging SPINS project. He has over 30 years of experience in HIV-related nonprofits, government programs, and advocacy. A member of NMAC's 50-plus Strong and Healthy cohort, he co-founded Rocky Mountain Cares and served as its board secretary. He completed a 4-year term on the CDC HRSA Advisory Committee, contributing to national discussions on HIV and aging. Since 1999, he has participated also in the NIH Identical Twin Gene Therapy Study and has also led leadership roles in various organizations enhancing his experience in aging with HIV. So Robert, thank you so much. And
good afternoon, everybody. Welcome. Thrilled to see you all here today. My name is Robert Reister. I go by he, him, and I am the patient liaison for the SPINS project for Colorado Health Network. Next slide, please. So here's a bit of my lived experience. Denver native and HIV/AIDS long-term survivor of 44 years, and I had an AIDS diagnosis in 1994. As Aaron said, I had 30 plus years commitment, and I use that word commitment to the HIV field because I made that commitment in 1994. Client Services Administrator, Ryan White Community Planning for 10 years. Some of our funders are here. I was also helped to develop the Friends in Need nonprofit in Amarillo, Texas, which was just a fundraiser, and then we turned it into a nonprofit to get our dollars going further. Local and national advocacy for 30 years, and the CDC HRSA Advisory Committee that just ended last year. The research study participant commitment is with NIH. I was an identical twin gene therapy participant for 25 years. And I did several studies, University of Colorado Hospital, one of which was talking about mobility and the gait and all of that. So now I get to see how that turned out. And then the Denver Commission on Aging. I was a former member of Denver Commission on Aging. They have a table out in the front as well. Next slide, please. So patient liaison, what is a patient liaison? It's a person with lived experience. And it is the Denver Principles in action. So if you're not familiar with the Denver Principles, there's also a table back there with Heather. She developed this beautiful rendition for the 40th anniversary in 2023. So to depict the Denver Principles, I was on a camping trip, and I asked the people that I was camping with, do you have a table? No. Do you have chairs? No. So I brought chairs and made a table. The Denver principles were developed by advocates from New York and San Francisco. They came together in Denver and went on stage with a big sign that says, "Fighting for our lives." So they took what they had. West Coast, East Coast came together. There was no table. There certainly weren't seats at the table. So they developed the table and the seats. In 1994, the Denver principles evolved to greater involvement of people with AIDS, or GIPA. Pictured here is Shadowcliff Retreat. This is where I began talking about HIV and aging back in 2016. GIPA is a global initiative, so the seats are in a round circle around the fire pit, the common cause. You'll notice that first bench looks a little newer. That's our bench. And then we went on to, in 2010, to MIPA, the meaningful involvement of people with AIDS. Pictured here is 2019 at the USCHA conference. I had visited Dr. Erlandson and some other folks in San Francisco. And Dr. Erlandson, Dr. Miley Karras, and Dr. Meredith Green put out a paper about the 5 M's of geriatrics. That, with Dr. Erlandson's permission, I was able to present that abstract at that conference. HRSA was the audience. I did not know it at the time, how important that presentation would be. But it was the missing link in order to get the SPINS project off the ground. I also had a type 2 diabetes diagnosis in August of 2019. Blood sugar level of 649 that I had to get down to 200 before I was allowed to travel. I knew what I had was important. I didn't know how important. So I made that commitment and I got that blood sugar down and was able to make that presentation. So that is that moment after I presented that paper. Next slide, please. So we talked about aging and some of the difficulties of it. So what we have pictured here is idyllic aging. The hill, if you would. Phil mentioned over the hill. So idyllic aging to me is you climb up the mountain and you're at the top of the mountain. It's beautiful, it's green, you're looking at the sky, there's a wonderful pond, whatever. You can see the road in the background. Our path as people living with HIV, this is the same area, but it was a little more difficult to get to that spot. There were boulders in the way. There were all kinds of things that you had to navigate in order to get there. The picture on the right is also symbolic of the path that people aging with HIV go down. No guardrails. We didn't have them in the early days. So as the patient liaison, I act as those guardrails because I've been down that road before. And just a little more comfort to the people because as you can see, there's the edge and the road goes that way. We don't know where the road is going to end. We don't know if a car is coming the other way. But I've been down that road and I can help assure people that it's going to be okay. Next slide, please. So my role as a patient liaison is to bring my 44 years of lived experience, all aspects of it, military family, Catholic upbringing, HIV, diabetes, all kinds of stuff, and to help the team in all aspects of the intervention. We have maintain the client-provider connection, which is really the one thing that is very, very important to me. because I am the person at the table that looks like them, that can relate to them. I'm a partner to the research team, and I ensure that matters most is in the client's care plan. Matters most to me is the biggest M of the 5 M's. So I also inform the SPIN's patient liaison team about our interventions. So the unique beauty about this, when HRSA designed this SPIN's project, patient liaisons had their own table. We all met separately and had monthly meetings. So we learned from one another. Even though Colorado Health Network was the only CBO, we learned a lot from the other agencies that were large hospital institutions or academic institutions. So there was something to learn from everybody. But the one thing we had in common is we all had HIV and lived experience. Our coaches also had lived experience. So that became a very, very valuable tool. I am part of a team in this baseball bullpen scenario. Sometimes I'm the coach, sometimes I'm the player, and sometimes I'm the line judge. But the line judge only comes into play when it's word count versus character count in writing abstracts. Next slide, please. So the benefits of being a patient liaison. I start out with the initial meeting. I have not met with every single client just because I have other duties to do at work, but I do meet with them in the initial meeting, and then I do the follow-up meetings. The follow-up meetings are a little less structured, where I can have a conversation with the individual. Being a Denver native, that conversation often can go down to a specific time period, a specific place, or specific people, which is great because you see the smile on their face when they're connecting with you. And it makes a big, big difference. After we go through each one of those meetings, I get with my team and say, here's what I think about this question or that question. One of the first suggestions I made, so I could get a better idea of the client's journey, is to have the full HIV med chart in the room. That way, if they did not know the name of the pills that they were on in the very beginning, like DDI is one that isn't on some charts, it is on the one that we have, pardon me, I suggested we have that in the room so they could at least point to that. Oh yeah, I remember that one. So that gives me an idea of their journey. Mine is from the very beginning. AZT, then DDI, then 3TC, all these different drugs. So I could kind of understand where they had been. 1994 is before HAART, highly active antiretroviral medications, before those life-saving drugs. So I also went through that period. And not knowing whether I was going to live or die, those medications did save me. So then the next question became, why did I survive? One very wise doctor in New York, Dr. Stephen Karpiak, had done some informal research with his clients, with his patients, and he found that if they were exposed to one of those 4 drugs, early drugs, just a little bit at least, that those are the people that were surviving. And I said, thank you. That's all I needed to know. The other benefits as a result of this particular project, we've done Ryan White Conference, we did a NASTAD consultation here in Denver, we did a white paper co-authoring, Speakers Bureau training, and Aging Forum, which we are here today, and webinars. Next slide, please. So tonight, or this afternoon, now we're going to have our conversation with our clients that have participated in the program. So I will turn it over to have them introduce themselves. Kent DeLongchamp.
Hi, my name is Kent DeLongchamp. I identify as a gay male and been positive since 1988 is when I tested positive.
Hi. My name is Vicente, and I'm a gay male who just tested positive in 2019.
Kent? There we go. How would you define what matters most to you as you age?
So I think that a lot of the stuff that we've been talking about today, the ageism, a lot of it applies outside of just HIV. It matters as a person, as a gay man, as a male. We can all experience all these different things of ageism and stuff like that. But kind of what matters the most to me is the continuity of my care that I do for myself, the continuity of care that I have with the team of people that I work with, and the continuity of care with the people that are in my circles, family, friends, and things like that. Keeping up with things that are changing so quickly today is one of the hardest things that I think has to do with ageism. Is you have to keep up with so many things, and so it's very important to have that continuity within your circles and within your people, so that you know where you're at, you can stay grounded, you have a foundation to work from, and when you need to shut off all the noise that's happening around in the world, you can focus on one thing, and that is because you've had that continuity and that foundation to grow from.
Wonderful. How did the iChange process help support you in focusing on what matters most to you when you age?
So iChange and Colorado Network for me has been a transformational experience. Many people that are HIV positive and long-term survivors go through stages of isolation and separation and depression and dealing with substance abuse or any of those factors that come about as we move through life. Colorado Health Network, I was down at Howard Dental getting my cleaning with David, who has been my hygienist for about 30 years. And he asked me how I was doing in my older days and whether I was enjoying retirement. And I said, oh, retirement is really taking care of my mom and doing all the necessary things. And he said, no, what are you doing in retirement for you? And I went, oh, me? I matter? And so he said, well, you know, we have this group here that meets and goes on a botanical walk on Wednesdays and has a social hour on Thursdays. And I'm like, oh, well, let me get that number. And within an hour, I'm on a botanical garden walk. And then the next thing I know, I'm in a social group. And the next thing you know, I am leading and a peer support specialist and leader. So walking through those doors took me out of all of that time of isolation, all of that time of separation, all of that time of feeling that I was alone and didn't have anything left to not give to the world, but I had pretty much done it all. And now I am back active and activist, an advocate, a voice, and it feels good to be back in the community.
Great, that sounds wonderful. What elements of iChange were most valuable to you? Like the processes, specific screenings, milestones, referrals? Anything stand out?
One of the things that I'm learning is that many people have a very, very difficult time speaking out and telling their story and feeling that they have something meaningful to contribute or to say. And so probably the thing that I have brought into support for the community and what has supported me the most is being the voice for those that cannot speak and also not being afraid to speak my voice and be who I am, and to not change or alter or in any way deter from who I am with all of my heart and soul, and not allow all of the rhetoric and the noise telling me that our differences are what we have to take notice of. We have to take notices of our things that we are together in, and that way we can grow and build community.
Yeah, you mentioned being a long-term survivor, and that can be very different for different people, depending on how long you have been positive, what that journey was like. Like I mentioned earlier, before 1996 is a very different journey than after 1996. What do you think is important for the audience members to know about HIV and aging to better support our community?
In today's political spectrum and the ever-changing field that we are all playing in, it is super important to remember that safe places and a place where somebody can go where they feel comfortable is truly important in today's world, because if somebody walks through a door and they do not feel that they can be who they are, or they do not feel that they can openly have conversation with, or they feel that they are being separated or dissension is happening, you are not going to get any growth, you are not going to get any involvement, you're not going to get any call in to whatever it is that you're speaking about. So just remember that setting a safe space, allowing people to be who they are in that space, assuring them that they will not be harmed in any way, any discrimination or anything like that is super, super important for the community. And that brings the support in from the people going through those doors and the people that are inviting you into those doors.
I love that. And you mentioned, Dave, talking about your retirement and what are you doing for you. So that's a good little uplift. Wonderful. Thank you, Kent. Next, I have Vicente. Vicente, how would you define what matters most to you as you age?
All right, I did a little things different. I took notes because I'm not so
Sure.
quick here. So for me, mental health and sobriety is my thing. When I was starting the iChange, I was in the middle of relapsing and I was seeking care. I was open and I shared my struggles. One day I was doing the thing that they had us do, where they test us, kind of like the physical, the thing, and I was off balance. And that's when I realized that I'm getting old and I can't put on my pants one leg at a time. And so I'm losing my spot. Slow down. Mental health and sobriety, that's what I think. Mental health, that's what's important to me. I'll just leave it at that. Mental health and sobriety.
Perfect. It is. It's very important. How did iChange process help support you in focusing on what matters most to you as you age?
All right. So I think of life in summers and instead of in years. Thinking of 20 summers makes me more value time than thinking of 20 years. So with that said, if I'm 55 and I think in summers, then I only got 20 more summers left before I'm 75. So I have more of an urge to do things. So they've put a fire underneath my ass as far as going to Machu Picchu, skydiving, having goals, whitewater rafting, flying. So now that I've done that, the next are the pyramids, but I wouldn't be able to do that if they didn't put me on the right track. It all started with just the balance thing that put me keep going and going, and now I've got community and people, and I'm starting other social groups, so I'm not stuck in isolation.
Great. And I love that you mentioned summers. You live your life in summers. To me, that's uplifting, happy, warm, a good deal. What elements of iChange were most valuable to you the process is, specific screenings, milestones, referrals, anything specific?
I get overwhelmed when I try to do too many things at one time. So with this group, and they've taught me to put my priorities in line. Instead of doing 5 different things at one time, I can just do one thing at one time and get it done. Do another thing, and if I do it right, I do the first thing and have a little bit of the next thing, continue a little bit of the next thing, and hopefully by the end of the life, I should be all complete.
Yeah. And you have reminders and things to help you keep track of that and what you're focused on now and what you focus on next.
Yes. When I go there, they help me stay organized. They are helping me with going to school and getting my CDL training. They helped me with the shadow box and that, which got me out of the house, which made me happier, so I'm not so long depressed anymore. And yeah.
And being creative.
Yeah, yes, for sure. And letting it out.
Wonderful. What do you think is the most important for the audience members to know about HIV and aging to better support our community?
For me, it was feeling worthy, allowing them to let me feel worthy that I didn't have. And if everybody can just feel the love that they gave, it goes a long way.
Yeah, great. So are there any success stories that either of you would like to share?
One of the experiences that me and my friend here did is the red ball. And the red ball, and Foster and Michael, anybody else that was at the red ball? Cool. The red ball is this experience of on December 1st, it is in correlation with National World AIDS Day, which happens to be my birthday. And 1988 was the very first World AIDS Day, which happens to be the year that I tested positive as well. So it's a very iconic date for me. The red ball last year, we had a group of us that we got to walk down a runway. We got to dance down a runway. I was picked to make a 5-minute video presentation of my life with HIV through my viewpoint, which was shown to everybody in that audience prior to us going down on stage. It was the first time that I had ever worn a tux. It was the first time that I had ever gone to a tailor to get a tux fitted for me. And the first time that I had ever gone to a tailor. So it was a huge, huge experience. That night was transformational for me. It will live in my memory forever and ever. And I can't imagine a birthday being any much better than going down a runway in a tux dancing to Saturday Night Fever. So.
Wow. Woo! Good for you. Vicente, any success stories?
I don't know what to say. Yeah, I don't know. Yeah, me. Yeah, you're right. I made it, and I got some sobriety out of it, and I made goals. Right on, man. Appreciate it. Yeah, you're right.
All right, with that, I want to thank our panelists. And one thing I want to say is that what you see here is the Denver Principles in action. So thank you, gentlemen. I appreciate both of you. Now we have time for questions, Q&A. Anybody have questions?
Thank you so much, and I'm glad the program has been so helpful for the both of you. Can you talk about the demographics of the program? I'd like to know how many women and transgender individuals, gender diverse folks are able to benefit from this. Because when we're talking about aging with HIV, a lot of what I'm seeing in this room doesn't reflect my experience. Or a number of the women or other gender diverse transgender folks that are here. And so I would love to hear how the program both includes categories, but also what the demographics of the program are, if you don't mind.
Okay. Haley, can you take that question for the demographics?
Yes. So in terms of iChange and who went through the program in the research study, I was going to get the exact stats, but I think it's about 65% male and 35% female. And so, though not everyone is here today, there is representation in that way. And then our groups, both in Colorado Springs and in Denver, that is about the same. Yes. Did I answer everything?
Yeah, I mean, because when we're talking about women who are aging with HIV, we're talking about things like going into menopause when you're 35. We're talking about not only taking care of yourself, but also the compromises that you have to make as you're taking care of your family. That happens to so many of us when we talk about family. We're talking a number of the strength examples in some of the earlier presentations when we're talking about women who aren't able to actually lift up a 10-pound bag of flour. That's a measurement that a number of HIV studies have done. We need to make sure that we're also talking about specifically both gender differences, but also talk in a way that it's inclusive around cisgender, transgender women, and gender diverse folks. And so just wanted to bring that into the space. So thank you.
Thank you.
Thank you.
Just to comment on that, we do have an open door where anybody is welcome to come to any of the social groups and any of the activities that we do. It's open to every single person. It doesn't matter whether your ethnicity or your sexuality or your identification. And as we grow and stuff like that, it is important to take notice of all of the things that we are lacking in and the people that we aren't communicating with. So thank you for bringing that up, and thank you for pointing that out. I appreciate that.
Any other questions?
I don't have any questions. I got a couple of statements I want to say. Pause does not equal death, and age equals wisdom.
Thank you. Any other questions? Bob?
Yeah, could you just read the Denver principles?
Yes. Heather Schulte out in the hall has a table that has that. There, Haley has it. You want me to read them out loud?
Well, I think it's just a guideline for all of us.
Yeah. Okay, so keep in mind, I mentioned MIPA and GIPA. They both have the term AIDS in it. The term AIDS isn't used anymore, but it is part of people's lived experience. I go by HIV/AIDS because I did have an AIDS diagnosis. The recommendations for healthcare professionals come out, especially to their patients who have AIDS. Number 2, always clearly identify and discuss the theory they favor as the cause of AIDS, since bias affects. I gotta get a little farther out here. There we go. Thank you. Always identify and discuss the theory they favor as the cause of AIDS, since this bias affects the treatment and advice they give. Get in touch with their feelings, for example, fears, anxieties, hopes, etc., about AIDS, and not simply deal with AIDS intentionally. Take a thorough personal inventory and identify and examine their own agendas around AIDS. Treat people with AIDS as whole people and address psychosocial issues as well as biophysical ones. Address the questions of sexuality in people with AIDS, specifically sensitivity, and with information about gay, male, sexual in general, and sexuality of people with AIDS in particular. Recommendations for all people. Support us in our struggle against those who would fire us from our jobs, evict us from our homes, refuse to touch us, or separate us from our loved ones, our community, or peers, since available evidence does not support the view that AIDS can be spread by casual social contact. Do not scapegoat people with AIDS, blame us for the pandemic, or generalize about our lifestyles. For people with AIDS, form caucuses to choose their own representatives, to deal with the media, to choose their own agenda, and to plan their own strategies. Be involved at every level of decision-making and specifically serve on the boards of directors of provider organizations. This third one is the one that I find the best. Be included in all AIDS forums with equal credibility as other participants to share their own expertise and knowledge. That is lived experience. Substitute low-risk sexual behaviors for those which could endanger themselves or their partners. We feel people with AIDS have an ethical responsibility to inform their potential sexual partners of their rights status. Rights of people with AIDS. To as full and satisfying sexual and emotional lives as anyone else. To quality medical treatment and quality social service provision without discrimination of any form, including sexual orientation, gender, diagnosis, economic status, or race. To full explanations of all medical procedures and risks, to choose or refuse their treatment modalities, to refuse to participate in research without jeopardizing their treatment, and to make informed decisions about their lives. To privacy, to confidentiality of medical records, to human respect, and to choose their significant others. To die and to live in dignity. I want to touch on number 4. About the privacy of medical records. The Denver Principles has evolved not just with MIPA and GIPA, but it evolved into the Patient's Bill of Rights. Back in the early days, we could not see our friends in the hospital because we were not family. We were not brother or sister. The Denver Principles were done in 1983. My first friend that passed away in 1985, I went to go visit him in the hospital, and his mother was there. I was shocked that they let me visit this person because I was not family. So it kind of stuck in the back of my mind why that happened. The particular conference that these advocates from New York and San Francisco, it was a nursing conference here in Denver. So I have a strong belief that those nurses in that particular AIDS ward at university may have been in that room and heard this and decided that they were going to treat people with a little more dignity. So the term family, the song "We Are Family," to me, that's what that means. And now we have HIPAA. So a long involvement, this document, as simple as it is, has really, really stood the test of time. So. I would also like to thank my incredible team, Haley and Aaron and all the other staff members here that I work with on a daily basis. Without them, a lot of this would it just wouldn't happen the way it has happened. And it's just been an amazing journey. So thank you all. And thank you to the other people in the room that I also work with as far as coordinating care, coordinating whatever it is with different organizations. That's very important. So thank you all.
So with that, I think this is the first forum I've been to where we're actually early. We do have a short break, but I think we can probably come back early for our final session, which is our call to action. I think every session leading up to this particular activity will really help in stimulating conversation within each of your groups, and I think some very thoughtful questions that were raised during the panel. So yeah, everyone, another 15 minutes and we'll reconvene. Thank you so much. All right, everyone. We are going to reconvene for our last session of our Aging with HIV Forum. This is our call to action activity, and it is a group-based activity, so everyone get their thinking caps on. The goal of this specific session is to identify specific actionable strategies to improve HIV care for older people living with HIV. Strategies that are practical, relevant, and also grounded in your expertise, your lived experience, your work, whether within the HIV sector or the aging sector. And as Haley had mentioned, we're big fans of the social ecological model. So we have 4 groups that are going to be split up at the individual level, the provider level, the organizational and community level, and then the system and policy level. So the color of your folder is more than just looking beautiful. It also represents which group you are going to be in. So if you have blue folders, you're with me as your facilitator right here on, yep, exactly. You'll see some stands with easels. There are Post-its that indicate which color you should be heading towards. Robert is in the back with the pink folders at the provider level. Haley is here to my right, your left at the organizational community level. And then Anthony Labady is facilitating the individual level in that far right corner. So we're going to take about 2-ish minutes to relocate and get situated. Huh? Yeah. All right, everyone. We have about 5 minutes, and then we're going to report out. All right, everyone. We are reconvening. Is everyone ready to report out? What did everyone think of the activity? Yeah? Good? Wow. All right. So we are going to start at the top. Haley? Oh. Haley. We're good? Okay. All right. Yay. All right, so we're gonna go in order as we see it on the screen with individual, followed by provider, organizational community, and system policy. Anthony, did we have a report out? You, yay. Excellent, all right. So we as groups are going to report out on our priority call to action at the individual level, yes. But also, if you have more than one. Excellent.
So our first one was to volunteer kind of as an ally to go to a provider appointment with someone, take notes for them, help them with questions for people who are not as good at self-advocacy and may not remember to ask the questions, and especially if it's a more stressful appointment, having somebody take notes so that you're hearing things, but also later you can get that information in a more organized fashion. Like a patient liaison, but just a friend, but also possibly in an official capacity as well. And our second call to action was to live authentically and let the world see you as a person. In other words, sharing your HIV status when it's appropriate, not necessarily advertising it, but not hiding it, and just living as your authentic self so that the community can become more aware, you can become more confident. That's it.
Sorry? Oh, we'll add at the end, but let's now go to the provider level. Christopher, of course.
I feel like the provider group turned into a group therapy group, and we got very deep and sort of like off topic and on topic at the same time, if that makes sense. And MJ's just mobilizing us. It's great. Anyways, so I'm gonna try. That said, I'm gonna try to summarize what we talked about as best as I can. And again, anyone in the group, feel free to interrupt me if you want to add anything. In terms of tools and training for providers, we talked about a couple of things. Overall, like an anti-ageism framework built into trainings for providers. Teaching providers to spend more time with older adults, that often the visits can be very fast and there's not a lot of time for like comprehension or really understanding someone's complexity. And just making services really accessible, it was kind of a key theme. In terms of the 5 M's, a lot of people in our group said, doing it at every encounter, incorporating it as a core principle, the 5 M's as a core principle into care with older adults living with HIV. So not just like a one-time we check in on the 5 M's, but like it's integrated into practice. And really matters most came up a lot, I think, reflecting that idea of everybody's in different positions in their life. I mean, again, people in our group brought up a lot of really different personal examples of where they were at. And so that really relates to matters most of not all people are the same walking into a clinic. I'm just going with this, y'all. You need to tell me if this is not right. And then what was the last question oh, no, what was it? Now I can't remember. Oh, being age friendly. Thank you. Oh, yeah. Something I'm probably not doing right now, speaking very slowly. And we had a good conversation on large print materials that a lot of people are like ushered into the appointment and like trying to read very small print on numerous pages of paperwork, and it is not really accessible or age friendly. Oh, yes. Okay. So thank you for clarifying that. So that we shouldn't assume that people have people are hard of hearing or have certain sensory differences. And then the last thing that I thought we had a really great conversation on is being age friendly, means recognizing that people of all ages have sex. And so we had a really good conversation on if you primarily served older adults, that doesn't mean you like take away all the things like condoms or references to sexuality or sexual health, because people of all ages have sex. So there you go.
Thank you. That was excellent. All right. So now our call to action at the organizational and community level. Who's our report out? Oh, yay, Jason. All right.
Okay, so the group came up with lots of great ideas, and there was wonderful dialogue, and I learned a lot, and I was taking notes. I was actually assigned to a different group, but I really wanted to be in this one. And so, so one of the things that we talked a lot about was collaboration and community resources, and that information also being available on paper. And there was once a circulation that was in place that's not around anymore, and I believe it was called ACE, or I forgot the name of the publication, but there was a great community resource, ACE, the ACE directory, and how that was missed, and just having a catalog of current programs and resources that individuals could engage one another on and find those. The other thing that we talked about was creating spaces that are, my word today is intentional, and so creating spaces that are intentionally welcoming and supportive to all individuals, and that would include introducing a different type of, or introducing training for community leaders and organizations, and then they would be able to place like a red ribbon sticker in their window or on a name tag or something like that, indicating that they are there to support all individuals. Another thing that we came up with was meeting people where they're at and going directly to those individuals instead of those individuals coming to us. And then the last thing that we talked about was leadership within in the community or in structures as a whole. And so we talked about how small community feedback sessions are essential, as well as listening to what individuals are saying and then being able to activate on that, and using just those little sections of time that we have with someone to really gain some insightful information to help support them. Did you get it?
Thank you, Jason. All right, and our last level is a system policy level, which is a really tough one, because I feel like it's tough making systemic structural change, but we did a great job. And so Helen's gonna report out.
Yeah, we have a laundry list of hopes and dreams. You should come check it out at a later time, but we came up with some big themes that we would like to see at a systems or policy level. The first one is collaboration between different agencies in order to respond to and reform or create policy. So some of those are like a state plan about aging with the LGBT communities in mind, and making sure that like the Alliance is part of that conversation, and the Office of Aging, and that they're working together to make sure that you know, throughout the state, all these different programs we have are integrated well. So, yeah. Also, payment reform and like economic security, both at like the healthcare systems level, but also for individuals who interact with these systems. So for the healthcare level, we have like Medicare and Medicaid reform. So really making sure supplies and medical equipment is accessible to folks, as well as medications was the other one that came up time and time again. And then for like the individual level, making sure that like housing is affordable for older folks, making sure that we have, that the federal poverty level really works for Denver. And yeah. The third theme we had was incentivize integrated HIV and aging services, kind of similar to the first one, but really making sure that doctors have the right training to serve folks with HIV, but also serving folks who are aging with HIV. Also streamlining resources for folks. I think the last group was talking about that old ACE resource, and someone actually in our group was like, I need that, but it doesn't exist at the moment. And the last one we had was structural stigma that needs to change. So we talked about all the barriers that people face in rural communities, and barriers that trans folks face, and so on. And Latino folks, we talked about how a lot of our systems just aren't built for folks with 2 last names. Yeah, I hear chuckles around the audience. Yeah. Did I miss anything? No. Cool. Thank you all.
Woo! Yeah. Are there does anyone want to add to any other group that maybe you weren't in, Foster?
We, as the aging with HIV, need to mentor them to be positive. Help them, like I said. Go to doctor appointments. Try to get them into care. Another one is that we need sexual help for people with aging, okay? And also for all of us in the community, whether you're in HIV positive or just whatever, social groups, especially sober social groups, on Friday nights, because then you reduce the tendency for people wanting to get drunk or get high.
Great, thank you, Foster. Anyone else? Anthony?
Somebody in the group that was speaking about organizational community, you were talking about educating businesses and having the red ribbon in the window. Recently, I was hospitalized at UC Health, and a huge preponderance of the people that came in and out of my room were wearing rainbow ribbons. And as a gay person with HIV, to be staying in a hospital and see so many of the providers that came into my room were allies or members of the community made what is always a crappy experience so much better. Just to see that so many people that were taking care of me were people that I knew would take care of me under any circumstances.
Thank you, Anthony. And with that, we've concluded our activity. It seems like it was great conversation all around. Karina is doing a fantastic job of capturing all of this, but we do intend to take photographs of all of our posters, all of the Post-its, and try to combine and distill all of the information that was shared among our groups. Again, these will all be delivered out as deliverables in the next few weeks as we're just kind of like wrapping everything up, and will be emailed to everyone who is in attendance. That being said, I would say either you can stay where you are, relocate back to where you were, and then, then we'll end with our closing remarks from Kelvin. All right, thanks everyone. You didn't have slides, did you? No. Oh my gosh. Is that like individually?
Okay, let's get this done. I know. It's been a long day, and I'm going to keep this short. Now, I see the looks on your face, Peter. I see you, Peter. We're old, and we know that when a speaker says they're going to keep it short, they never keep it short. My response to that is, it was short when I wrote it. To close this day, I'm here to give you some encouragement with something that all of us can do, which is inspired by my friend Mary Jane. Where's Mary Jane? She's my inspiration for this speech. Because it doesn't matter who we are. It doesn't matter what we look like. It doesn't matter how tall we are or how short we are. How thin you are or how thick you are. How light you are or how dark you are. How old you are or how old you are. The encouragement I'm giving you today is to perk up. Perk up. Think about who we are and what we have witnessed through this collective journey. Sometimes I still can't believe I'm here. I have to pinch myself. How did this happen? It is truly a miracle. And I say to myself, Calvin, perk up and share who you are with the world. So who am I? I'm Black. I'm queer. I'm joyful. I'm extraordinary. I smile. I laugh. I have teeth. I have lost teeth. And the teeth I bought are mine, Howard Dental. I'm cute. I'm sexy. I'm fashionable. I'm unpredictable. I'm tired. I'm full of energy. I'm content. I'm seasoned. I'm old, and I embrace that. I am all of these things because I have journeyed through life, and so have you. We have nothing to prove. We have seen it all. And we want to see more because life keeps going, so perk up. Surprisingly, I am now the patriarch of the Gibson family. I asked my family, what are the benefits of being the patriarch? Do I get to wear robes? Do I get to tell young people what to do? Do I get to carry a crystallized walking stick? Yes, I do. This is what happens when a gay man becomes the patriarch of the family. You perk up. I have a blanket that my grandmother made me. It has to be over 50 years old, and like us, the fabric has been worn and torn. And after all these years, it still provides me warmth, love, and the comfort of childhood memories that I deeply cherish during our cold Colorado winters. But like that fabric, we age. And sometimes we no longer thrive to be all that we can be in life. Sometimes we allow our talents, accomplishments, and greatness to fade away. And like that cherished blanket, we have to be washed, stitched back together, and perk right back up. So try something new. I decided to get myself a little part-time job with the Denver Broncos. It's not much. I'm an usher. I collect tickets. I look at how beautiful the men are. It's a perfect. If you like to people watch, it's a good job. But guess what? I was named Rookie of the Year. I'm 64 and I'm still acknowledged. It's because I tried something new and I perked up. Enter a room like you own it. I learned this from Dr. Maya Angelou. Every time Dr. Angelou walked into a room, her aura was so big that I swear she floated. I'm sure that Maya had feet, but to this day, if you ask me if she walked into the room, I would say, nope, she floated. And the older she got, the higher she would float. Perk up. As the old saying goes, you look how you feel, and you feel how you look. Don't be afraid to express yourself. It's cool when our elders are strikingly fabulous. Shall I say that again for the people in the back? It's cool when our elders are strikingly fabulous. If you don't get what I'm saying, then visit a Black Baptist church on Easter Sunday. Those elders perk up. And they are fabulous. One night, where's Robert Reister? There's Robert. One night I gave Robert a leather crown. I put it on his head and I watched him perk up. His smile got bigger. He grew about 3 inches taller. I looked at him out of the corner of my eye and I saw that he was close to beating his chest. I wouldn't have been surprised if he told me he slept in that damn crown. So like Robert, appreciate the joys in life. Appreciate it. Appreciate everything. Appreciate when you walk outside and the sun warms you. Appreciate when someone smiles at you. Appreciate the people who tell you they care about you. Appreciate that you are here for a reason. Appreciate all of the lessons that you have endured. Appreciate when people want to hear your stories. Appreciate the way you feel when you accomplish something that you thought that you couldn't. Appreciate the way your mind races with ideas at 3 a.m. because it means you're still dreaming. Appreciate the moments you catch yourself smiling for no reason at all. Appreciate all of the blessings in your life, no matter how big or how small. For you are not only survivors, you are conquerors. So perk up. It's time to honor your growth, your experience, your wisdom, your journey. Everything in your life has brought you closer to being your authentic self. For me, that means not running away, but reinventing myself as an elder. A few months ago, I became Father Fuck It with the Sisters of Perpetual Indulgence. Fuck it, F-U-K-K-I-T. I gave myself the title Father of the Village Peeps. I wanted to say Father of the Village People, but I thought that people would start doing YMCA, and Trump has screwed that up. So I'm Father of the Village Peeps. Now you may ask, Calvin, why Father Fuck It? I like to say fuck it. Fuck it. It's fun. I'm old. I can do that. It's my authentic self. I want to tell our stories, our struggles, how we fought back and how we now thrive. I know that it's simple, but we don't always have to do the work. We've done the work. That's why God invented young people, to do the work. Now that we know that we hold the lessons, we hold the wisdom, We hold the values. So perk up. I would like everyone to repeat this mantra after me and say it with conviction. Through my actions, I honor me. Through my words, I honor me. Through my journey, I honor me. So perk up. Dr. Angelou once said, our elders, their smiles assure and reassure. Life is worth the living of it. Do it with your whole heart. In closing, I told you I would keep it short, Peter. He didn't believe me. In closing, I would like to say, in this very room, there's quite enough love for one like me. In this very room, there's quite enough joy for one like me. There's quite enough hope and quite enough power to chase away the gloom. For a spirit is in this very room. In this very room, there's quite enough love for all of us. In this very room, there's quite enough joy for all of us. There's quite enough hope and quite enough power to chase away all of the gloom. For a spirit, your spirit, and your spirit, and your spirit, and your spirit, and your spirit, Mark, and your spirit, Gretchen, and your spirit, Foster, is in this very room. Blessings, namaste, ashe, and perk up. Thank you. I love you too. My inspiration, you get it?
All right, everyone. With that, that concludes our inaugural HIV Aging Forum. Thank you so much for coming. Woo! Haley, come up here. I just want to say a huge thanks to our incredible community of clients, our programs, Haley, our committee, our planning committee, and we do have a sunset social immediately after. So we please encourage you to go to the lobby. Before you all depart, just want to invite our CEO, Dara Vigil, up to the front for a few remarks, and then you're all free to go. Thank you, Daryl.
Thank you, Erin. And I just really have very few words or a few remarks to share with you all today. First of all, I had a ton of meetings today, but I was very fortunate to be able to attend much of this forum via the live stream, and I learned a lot, and I know you all learned a lot as well. So I just want to share quickly, for those of you that don't know, the mission of Colorado Health Network is to equitably meet the evolving needs of people affected by HIV and other health conditions through prevention care and advocacy. And today you have all been here talking about those evolving needs of people living with HIV. You all learned today that over 55% of the HIV positive folks that are served today are over the age of 50, and in just 5 years, that's going to climb to 70%. I'm so proud of Erin and Haley and their professional collaborators and team members for creating innovative programs to address the needs of our aging clients and to implement these programs not only here in Denver but across the nation, and working in the short-term future to help other organizations, other AIDS service organizations to implement these programs. It is so important. So thank you all for being here. I really appreciate it, and please enjoy the happy hour, or what are we calling it? Sunset Social. Thank you very much.